Now mine, oh, there it goes.
Good afternoon, everybody. It's 12:00.
Recording in progress.
We'll call the meeting to order. I guess happy May 1. Self-introductions.
Nancy Wise, Commissioner.
Zano Giro, Commissioner.
Pat Malone, Commissioner.
Curtis Wright, citizen member.
Liz Irish, citizen member.
Chaz Jones, citizen member.
Everyone's here. Take it away.
Hey, thank you, Mr. Chairman. For the record, Rick Krager, Chief Financial Officer for the county. Good to see you all. Happy Monday and welcome to day 5. So what better way to start a Monday than talking about budget, right? So today is Health Day. We have both our health department here as well as our community health centers. So these represent 2 of the largest budgets in the county. So there's a lot of information you're going to hear today from both the health department and community health centers. And first on deck is April Campbell and April Holland. Sorry, geez. April Holland and her staff are here to talk a little bit about the health department. But I'll jump in first to do a quick overview health department budget. As soon as I get my clicker going here. There we go. Okay. So again, as I mentioned, a relatively large budget here in the health department at a $46.8 million is what our current service level is estimated to for 23-25. That's about 10% above our adopted budget. And we'll talk a little bit. You would typically expect that to be a little bit higher, but been a lot of one-time revenues through COVID that have disappeared. So that's one of the things that kept the actual percentage growth down a little bit. In total, the department is being recommended that the department receive additional $1.5 million, which includes 11.32 FTE, which we'll talk more about later in the presentation. That brings their total proposed budget to 48.3. Which is altogether about a 14% increase for next biennium. They too have a vacancy factor. Not all programs in the health department were hit with a vacancy factor because they have a lot of dedicated revenue resources, but those that are related to the general fund represent about a 7% vacancy factor. So again, using my little formula, a little bit on the higher side, but health department has had a few areas that have had some pretty high vacancy factors. One that comes to mind is navigation. I know in our computation of that, I think we had somewhere up near 20% on a particular vacancy on that. So again, as I mentioned, we don't want to put a lot of those higher ones in place. So we used a max of 10%, but in average, they came to about 7% in terms of total vacancy factor. Again, the primary budget drivers very similar to the rest of the county. Again, the big piece in terms of driving their budget up is the additional 11.32 FTE. The one piece that I will note as you look at the numbers, in particularly, as I always say, when you see larger amounts, the 158% in contingency, that is primarily related to our mental health housing. We've had some pretty significant investments in those areas. So there will be some contingency dollars that we'll have to wait and see if we're going to be able to use all of those, but at some point there may be a budget supplemental that will have to come forward to release those. But at this point, we have a relatively large piece there. I should also mention, and I know Damien will probably talk about this in his comments, that there has been some renegotiation of IHN capitation rates. Yes, sir.
Would you get a little closer to the microphone?
Closer?
Yes.
Okay.
Or the microphone.
Or be louder.
Okay, I'll have my voice is crackling here a little bit today, so I apologize. I'll try to speak a little bit louder.
That's great.
Okay. So again, there will likely be some comment from Damien about some of the increases that we're seeing and that he's successfully negotiated, county successfully negotiated in terms of release increases for behavioral health. So categorically, Again, just to provide sort of the outline of how dollars are actually being used going into 23-25. Personal services continues to be the largest piece. So slightly lower than 21-23, but a lot of that is again offset because of some increases related to contingency. That's the biggest change that you will see in the pie chart. So just on the basis of distribution, that's where you see a little bit less in the other categorical areas. So again, not a lot of changes there, other than, like I said, in the contingency. In terms of the actual resources, specific to the health department, so they have several funds in which they draw from. The general fund, obviously being the largest portion of dollars that is specific to the health department. So again, as I mentioned before, I like to try to break it out so you understand the discretionary versus the non-discretionary, the dedicated dollars. In total, about 67% of the resources that go to the health department are specifically dedicated dollars. Most of this is related to a lot of the operating grants we get from Oregon Health Authority, as well as a variety of other service charges such as environmental health, Medicaid billing, and other charges for services, miscellaneous charges for service. So again, the majority of the general fund that is for the health department is dedicated dollars. That leaves about 10.7% in total is what is discretionary that goes specifically to the health department, as well as the local option levy, which is a very small portion. You can see of 0.72%. There is also this one you might recall when I was talking about public works. The health department is unique in that they have their own health management service fund. This is what kind of the equivalent of an internal service fund where the cost of their administration is spread across a variety of their divisions within the health department. They also have a shared fund specifically for business services as it relates to both the health center and the health department. And that includes like our billing and our coding, business services related. So those are spread across both those departments. For the purpose of presentation, I'm sharing this, the health, and you'll see this later on, the management services piece in the health department. But like I said, it's shared equally between each, the health department and the health centers. And then there's a very small portion that you can see that we have in the special grant fund, about 2%. And this is primarily related to a state legislative grant that the department received this last biennium. So that sums up their entire revenue sources. So then lastly, just to quickly go to set the kind of framework for April here as she starts to go into the specific divisional areas. You can see sort of some of the different areas in the increase changes. Public health, to no surprise, is where you see the decrease. Again, back to a lot of this is winding down from COVID. There was a lot of one-time resources that we had in the previous budget. So as we start to right size that back to normal, that's where you see the biggest change. Behavioral health, reverse that is to no surprise the biggest area that you're seeing in terms of increases. And again, as I mentioned, a lot of that is related to the housing dollars that was specifically received this last biennium and will continue, as well as some of the increased rates that we will be seeing as it relates to behavioral health. And then lastly, like I said, the health business services piece. Again, just a little bit of a soundbite as it relates to the financial services department. You might remember when I was talking to you about public works. When you get to financial services, you're going to see a relatively large increase in that because of the centralization of financial services. What offsets that is this is one department that contributed a great deal as it relates to that centralization along with public works. So when you look at health business services and you see that decrease, remember that is a bit of an offset to the increases that you see in the financial services department, which you'll hear next week. So again, overall 10% current service level, 14% proposed increase, and 14% increase in terms of the proposed budget. So with that, I'm going to shift over to April and let her take you through description of the various departmental areas.
Hi, good afternoon. Can you hear me okay?
Great. Hi, my name is April Holland. I use she, her pronouns, and I serve as the interim health department director. And I've done so for about 6 weeks. I came here as the public health administrator and deputy director of public health in December 2020 and quickly got engaged right into COVID-19 vaccination. While some of this is new, some of it is bread and butter, and I've got my colleagues here. We're going to go back and forth first with public health and healthy communities, then have our my colleagues from developmental diversity come up, and then last but certainly not least, Damian Sands with behavioral health. So I'm just going to jump right in, and I'll let Sarah Rocio and everyone else introduce themselves as their items come up. So I'll start with this health services overview. This chart is affectionately known as our rainbow chart. And while it's a little bit aged, you can see an old logo or two on here. I still feel it illustrates the spectrum of services delivered here in Benton County. It shows that from overlapping types of centralized services you see in the center. These activities, promotion, provision, and protection, and shared platforms for analytics, records, and billing, were able to deliver services spanning from the individual person-centered, which is primary care, and you'll hear from Carla and team with the community health centers in a bit, all the way to those benefiting community health over to the right. So this presentation, as you know, is geared specifically to health department, and I will jump right into the next slide. So you see here our vision and our mission listed. Wanted to list out what you'll see included here in the coming slides. These are listed in alphabetical order. I have no favorites. There's behavioral health, developmental diversity, the health business services, health department administration, and then public health and healthy communities. And I'll just point out that though healthy communities and public health are both distinct divisions within the health department, they both fall within public health in terms of the local public health authority statutory responsibility. And so they're combined for these purposes. So this organizational chart might appear a bit busy to you, but this is a pretty high level organizational chart. Any one of these folders could be opened up and contain a lot more information. So the dotted lines over to the left side indicate ties to the community health center's budget, and we can touch more on that later as we get into the details. So health department administration is the office of the director, and it includes some programs that serve all of us here, including health communications, health equity, quality improvement and accreditation, and our budding coordinated homeless response office, possible through HB 4123 and born from the extensive efforts of our home opportunities planning and equity or HOPE program. And I'll invite my colleagues, Sarah Hartstein and Rocio Munoz, to cover public health and healthy communities.
Good afternoon. My name is Sarah Hartstein. I use she, her pronouns. I'm the interim deputy director of public health, backfilling for April Holland. As April mentioned, public health and healthy communities are separated on the health department organizational chart, but one when it comes to statutory responsibilities and funding. Public health strives to protect and improve the health of people and our communities in Benton County, and includes immunizations, maternal and child health, women, infants, and children program, environmental health, And then many of our prevention programs that live within healthy communities, including harm reduction, and problem gambling, tobacco prevention, et cetera. I won't go through them all. Rick, would you like to talk through the red box, or shall we reference that for later?
I think you can go ahead and continue. We'll get to that when we get to the policy packages thing, just for the committee's awareness. What we've done in here is, as always, we're talking about the current service level, but in the red box, we're reflecting what more is being asked for when we get to the policy packages.
Next slide, please. Thank you. We've listed out the various public health programs for you to review at a later time. We won't go through them all today. We know that we have a limited amount of time with you. But I wanted to just take the opportunity for Rocio Munoz to introduce herself.
Hi, good afternoon, commissioners. Buenas tardes. My name is Rocio Munoz, and I am the interim Healthy Communities Division Program Manager for the last 4 weeks or so. So I'm just very thankful for the opportunity to be here with you and to be in your presence and to be accompanying my colleagues here. So I won't take more of your time since there's lots of more discussion to have, but just wanted to take a moment to say hello to everyone. Thank you.
We can move through the next set of slides just for your review at a later time. It highlights the variety of public health programs that we offer to our community.
So much. Thank you for joining us, Jasper.
So I'm Jasper Smith with the Benton County Developmental Diversity Program, and we serve people in our community who are identified by state and federal criteria as having an intellectual or developmental disability. So we help support them to have the lives that they would like to have in our community, and we help our community support them to have the lives they want to have in our community. I've managed the program for almost 20 years in September, and we've seen a lot of changes over that time, but the core of what we do hasn't changed significantly. And so we serve children and adults throughout the lifespan, birth to death. And so we provide lifelong supports for mostly services coordination, which is kind of identifying and accessing and assessing needs for people, and then planning for their supports and hoping to monitor and follow along and make sure they get the things that they need. And so we can help people access housing and jobs and medical care and mental health supports and just whatever they might need to have successful lives in the community. And Benton County was the first county in Oregon to have a developmental disabilities program. And so we've seen that growth over 50+ years, from kind of a largely institutional system into a fully deinstitutionalized home and community-based setting, where we have probably over 60 homes that support people. And we also provide in-home supports for people in their own homes and apartments, and support people in their families, and support well over 200 people in kind of job supports. And all of our services are kind of person-centered and family-centered to support them in the ways that they're telling us they want to be supported. And we're funded through kind of the long-term care side of Medicaid. So the Oregon Health Plan kind of funds medical supports on one side and also long-term care on the other side. We're on the long-term care side. So all the supports we provide are supported through Medicaid funding. And the bulk of our support comes from the state and the state Medicaid program. So most of our budget is going to be determined by what the state legislature does here by the end of June. There is a small portion of county funds that we also use for matching with federal Medicaid funds. So we're able to basically triple whatever the county gives us with Medicaid reimbursement. And we work closely with a lot of community partners. So we don't provide the group homes and foster homes and in-home support agencies, but we coordinate with them and we help them get licensed. We help monitor for quality, and we help kind of refer people to those services. And so we work with a wide network of community partners to provide these services. And there's probably well over 1,000 people in Benton County that are employed supporting people with developmental disabilities. And I don't know what other questions you might have, but we have experienced pretty steady continued growth, and we will be having more growth going into the next biennium. So we are hoping to add some positions to respond to the growth that we've seen. We supported people through the pandemic and saw actually growth through the pandemic. I think Benton County and actually the state of Oregon did very well supporting people safely. Nationally, the death rate for people with developmental disabilities was 2.5 times higher than the general population. But in Oregon, the death rate of the general population was 6 times higher than people with developmental disabilities. So our system did a very good job of protecting people and keeping people safe. And we saw, a lot of coordination with public health and others to keep people safe, and was very effective throughout that. And as we're easing out, we've seen a large increase in people seeking services and supports. So we're hoping to meet that need with some increased staffing in the next biennium.
Thank you so much. That's great.
Good afternoon, members of the committee. My name is Damien Sands. I'm the Behavioral Health Director here at Benton County. Let's see if that's good. Is that good for everybody? A little bit? Yes? Okay. Let's see. So I'll be speaking to from the lens of the Board of County Commissioners representing our local mental health authority. A lot of the stuff that you just heard from Jasper really does apply for behavioral health as well in terms of our funding streams. So as we go through this, we're hoping to sort of add some clarity around these funding streams and distribution between the health department and the CHC. You'll see a listing on the list on the left of all the areas in which we do receive funding. So we really do have a diverse funding stream in terms of how we operate. This is critical, obviously, for being able to be a functioning environment for us going forward in terms of us being able to add on additional FTE to meet the need, which most definitely is there. Next slide, please. So I think for the sake of brevity, I won't dig too deeply, but I think I would like to just sort of touch upon maybe the 20,000-foot level of some of these areas, just so you get a sense of kind of where a lot of the funding and a lot of the service provision is going. So in these first two, you'll see adult outpatient and children's and family services. This is probably going to fall into the category where most of you are familiar with the concepts of day-to-day mental health services. That's in which an individual goes to the door, meets with a counselor, engages in some type of therapeutic relationship for however long they need until they get to a place of wellness and return to the community, and hopefully life is bright and happy going forward. This is sort of the bulk in terms of capacity of numbers. So the important thing to think about here is when you think of numbers, if you think of a bulk of numbers here with a lower acuity, requiring less time, less energy, less investment, and then we go all the way on the other end of the spectrum, probably a smaller number, but with a much higher level of acuity and intensity, and therefore more services that need to be bridged around them. So as you see, we progress through these slides, you'll see this transition. I've tried to make it some type of coherent flow to this. So if we go to the next slide. Thank you. So if you think of those two sources as being kind of the bread and butter of behavioral health, traditional services that we are really proud to offer and essential for our community members, I would say that these fall into what we would refer to as more sort of progressive services, but we've seen them to be highly effective because of the evidence-based practices that are associated with. First one is ESA. This is an amazing model that offers diversion from higher levels of care, specifically hospitalization, with a decrease of 50%. So many years ago, if an individual was identified with a form of ongoing psychosis, eventually leading to a place of schizophrenia for the individual, we would consider that person a part of the SPMI, the severe and persistent mentally ill. Trying to stay away from acronyms. Doing good. Okay. And in which that would kind of be, we would all understand that that would be their pathway. This is a model that intervenes right at the beginning of a person's first break in psychosis and offers a pathway so they can stay within the community, stay connected with family members, and not go on that long-term trajectory. ACT is kind of the other side of that coin. ACT is about those individuals who are now at the end point of their diagnosis. Now they have that acute level of schizophrenia in which they've probably seen a long-term relationship with some type of hospital provider, but now we're wanting them to reside in the community versus an institutional setting. We have an active caseload. It's always completely filled. It requires high levels of case management services on a day-to-day practices, keeping individuals in the community. Some are housed, some are unhoused. So these are our most acute in the population. But what they do is allow folks to function in the community versus remain in that secure hospital setting. The last one is peer services, and I'm not sure if you've heard of this terminology before, and it's an emergent form of care within behavioral health, but it is an absolute wonderful model. And that's basically individuals who have gone through their own life experience, their own interface with some type of behavioral health service. And what that basically, those peer services do, is it allows an individual who's gone through that service to work with someone who's just come into it. And it creates a great level of, it levels a playing field, but it also creates a great pathway of access. It allows sort of assurance, allows a way for that person to navigate through the system, which can be hugely complex when they're dealing with something really acute. Next slide, please. As I'm sure you've heard in various budget presentations, and you will continue to hear, and I know that you're all fully aware of this, housing is obviously something that's up front and center for us as a community, as a region, and as a state. So we do offer a bridge services around housing supports for those with some type of behavioral health condition. In addition to that, we also have a psychiatry and nursing program, which allows for prescription medication for us to be able to engage in some type of psychotropic intervention in a person's care. Next slide, please. Again, these two are I left sort of to the last piece because of the critical need that we are seeing right now within our community. So the first one's around such treatment. You've probably seen in the media a lot around some type of impact from whether it's opium or prescription drugs or levels of use in which it has the potential for some type of critical situation pertaining to that person's comorbidity. Basically, what we see right now in our SUDS community is an environment in which individuals can easily get access to drugs with a high level of lethality, that have a high level of need, but perhaps have minimal experience and even understanding how to navigate that system. So it's an emergent program within Benton County. It's something that's really only sort of gone on for the last few years in a more robust format. What I will say, I'll call out Heather, specifically our new manager in that area. It is one of those ones where as we have begun these services, the need has only grown, and that's really because of awareness. So I wish, well, I could say there isn't exponential growth, but there most definitely is going to be exponential growth in this area because that need is so great. And then the last piece, and this again for the commissioners are probably well versed in this area in talking about crisis services pertaining to some of the changes at the state level. Our crisis and forensic services really are an absolute, not to overuse the term, critical component of our service array within the county. Ultimately, where we are heading towards, and as all of you are familiar with opening of the new crisis center in 2024, knock on wood, we're going to be able to stand up a 24/7 model of crisis response. It's going to be tied into a service line, which you also may have heard of, is a 988. I'm still ironing some things out there, but it's basically the ability to interface with these critical services in the simplistic of ways. Simply dial 988. It will get you connected to a local council, and we can respond in turn. So these robust services are needed in many, many ways, but they also pertain to how we manage individuals who have been discharged from the state hospital. Right now, the responsibility that is being placed upon the counties at this time is a large responsibility to manage that service. So you'll hear a little bit around this in the budgetary component in terms of the funding stream. OHA has also done a carve out around our CFAA. So the CFAA is basically the state award contract that comes directly from OHA to us, has carved out a portion of these funds, which we received in January, in addition to us negotiating a rate with IHN and again, not to use more acronyms, but PMPM, per member per month. So between those two things, we now have a funding stream that can stand up a model so that we can get additional staff on. That actually has already taken place, and those positions are outside of this budget request. But it just so you understand, you'll see a lot of robust need, but that actually is going to be a separate budget item that we don't have to quite worry about in this one. Next, and I think
SUDS stands for.
Substance use disorders. So yeah, we used to refer to it as alcohol, tobacco, ATOD, alcohol, tobacco, and other drugs. And, our acronyms try and stay current. So we sort of move through a cycle over time. I often find myself still talking about alcohol and drug use, but.
Thank you. And one more question while we're on it.
Yes, please,
What is
Commissioner.
PCI services there?
It's the second row under.
The PC, that is a good question. I'm used to PCI meaning parent-child interactive therapy services.
Oh.
So that's my definition in terms of how we're doing. I think that one actually, when I saw it on there being listed from crisis services, I'm assuming it means basically without getting into it, but it's an interventive model around a third-party therapist working with a family who are in crisis so that they learn cognitive skills about how to interface with the child in an appropriate setting. It's a wonderful model, complex, but very effective in terms of showing appropriate behaviors between the adult and the child and how to sort of model it. Simply put, if you haven't seen good modeling, you may not exhibit good modeling. And next slide, please. And is that it? Okay, look at that. We blew through it. Great. Thank you.
Thank you so much. And committee members, you'll hear more from all of our colleagues as we get into our goals and our policy option packages. Yes.
Before you go, I actually had a question of both in developmental diversity and in behavioral health, just out of curiosity, or curiosity is not the right word. Out of interest, what percentage of individuals and families in the county are struggling with these problems, and how has that changed over the last 5 or 10 years?
So an intellectual disability is by definition people who score in the first percentile on an IQ test. So it's about 1% of the population. And then the other developmental disabilities we consider people with autism or cerebral palsy or epilepsy. They also have to score in the first percentile on an adaptive behavior skills test. So we basically serve about 1% of the population, and the percentage of the population doesn't change that much, but the population has increased. And there's some wiggle room in there to, we have seen kind of significant increases in diagnostics around autism to where, it's probably more like 1 to 3% of the population that we're serving.
And thank you for the question, Curtis. I wish I could say that for all of the good work that is done within our field, that we really are getting we're managing to turn the curve, but the reality is quite the opposite. And if we look at our suicidality rates, and I would refer to that as the sort of canary in the coal mine, state of Oregon is in often scores within the top 10% around the nation. And if we look specifically around the diagnostic criteria for individuals suffering from some type of mental health condition, we know that the impact of the pandemic have been severe. We are still dealing with that as an outcome. And one area we're seeing this specifically played out in is actually at the school level. We are seeing individuals who are returning in a school setting with minimal pro-socialized behavior, with a lot of need, and that's multiple school years. We're seeing teachers really sort of exasperated in the way that how to handle these things. But there most definitely is across the board, you know, and across the age ranges. This pandemic has definitely had an impact upon our overall health. So, the state in its wisdom did recognize this, and the funding that you're seeing that we'll discuss about here, a lot of this was actually during that time, and they recognized this wave of need around behavioral health. So they put through a lot of policy option packages, which we are now using here. So the same model that happened at OHA. So they put a lot of POPs through to be able to get funding to the county so that we can start to have more of a robust response to this need, because right now it is definitely the need is greater than our ability to respond to it.
And if I could add something, and in the kind of intersection here, probably about 1/3 to 40% of the people we serve also access kind of mental and behavioral health services, and we have a small carve out that does that services for folks. But so we have the people we support have multiple medical, behavioral health, other types of needs that we support in addition to kind of their community access.
Thank you, John. Thank you. Thank you.
Thanks so much. So, I'm going to just depart just a moment to jump into health business administration. As Rick mentioned at the start, it serves both the community health centers and the health department. And you'll see here in this, I'll see you in a minute, this health business administration provides data services, health information management and our records, and business services, including billing and coding and credentialing of medical providers. And I think this is where we jump into our goals. And I just want to invite any of my colleagues up here as a goal that pertains to your area comes up. So for the first goal is to use our health equity assessment results to inform the development and implementation of a health department-wide equity plan that will improve our capacities and skills. I do want to note that in terms of how it's funded, this actually will be funded by our current service levels. We do have a policy option package for our health and all actions work, and that request funds of some things that are outside of this assessment. So apologies for that error.
Quick question there. When you refer here to the organizational health equity assessment, is that the assessment that Sarah Siddiqui has in her budget? No, this is a separate and parallel. Okay.
Yeah, we are working closely with Sarah, and she's involved in many of our conversations around our health department equity assessment right now. So in a lot of our work, we're in assessment phase and are going to move into a planning and implementation phases, and this is one of these.
Oops. Oh, there. If I could just add, I would just echo what April was saying about Sarah being engaged in this effort, but to distinguish between the two assessments, I think the health equity assessment definitely started first. It's been underway for some number of months. And it is a requirement of public health reaccreditation, correct? Oh, sorry, public health modernization. So it has a very specific requirement that it's meeting, and it is more specifically targeted to the health equity component. Whereas the equity assessment that Sarah, our county EDI coordinator, is leading is really broader and would apply to the entire county organization. But we're definitely taking efforts to make sure these are connected and that Sarah is engaged in both.
Thank you.
Thank you. Okay, goal number 2 is another example of planning moving into implementation. We will use our climate and health assessment results to inform a climate adaptation plan, protecting our communities from environmental health threats through public health interventions. And this will be achieved through our 23-25 current service level. The third goal has to do with severe weather sheltering. We have a goal by this fall to open a shelter for overflow severe weather sheltering based on temperature thresholds or air quality that is not dependent upon the official declaration of an emergency, that ensures that folks can stay healthy in severe situations, severe weather situations. Our intent is that this would be operated by a contracted service provider and a trained volunteer network. And then the funding sources could be blended. I'll speak a little more on that in just a minute. And then, the structure that we foresee is one where we have a structure leased or a facility leased or owned by the county and or partners, and importantly, would provide low barrier shelter services to those who could face health effects in poor weather situations. So as the commissioners know, and to inform the budget committee, we did have over this last winter season a contract with a local provider to have severe overflow weather sheltering. Most of it was hotel sheltering due to the absence of a dedicated facility to provide these services. And some of it was overflow when hotel rooms weren't available at a local church. The hotel sheltering it worked in a pinch, and it was sort of a way to ensure that we had a place to house people in these severe conditions as a start. And we are working on that next iteration of ensuring shelter for folks moving forward. This states that this would be funded by a pending future grant. I want to share with everyone here that, we had an opportunity for funding that looked very promising, and I'm not sure at this moment whether that will come to fruition. However, our amazing coordinated office folks, including our contracted grant writer and others, are partnering to work on a funding source for this. Okay, so for the fourth goal, this includes using data from our health equity assessment and informed by the Home Opportunity Planning and Equity Advisory Board's recommendation. Our Benton County Behavioral Health Division will develop a plan to align appropriate services with our coordinated homeless response system efforts by January 1, 2025. A lot of progress on this front is happening as we speak, and community partners coming together at a common table to address these needs. And of course, our behavioral health division is an integral partner in these conversations. And this would be funded by our current service level as well. Goal number 5, Damien, would you like to speak to goal number 5? I think that he could provide a much better overview than I could. Thank you.
Just want to make sure I abridge myself of what we've written. Okay, let's see. This sounds like a great idea. Okay. So, as you are aware, and you may have seen this in the media and or heard through your local commissioners, we are currently in a place of response to changes that were made through the Mossman order. The Mossman order specifically was an order that required the longevity of stay at the state hospital to be amended to a finite amount of time. The intent behind this is around the individual's liberty. Certainly, it's a very noble intent and something we definitely honor. Now, with that, there come some consequences. And those consequences are being able to address those needs now at the county level versus in the past, how they would have been addressed at the state level. The challenge with this is that we would have individuals who are coming out of a hospital setting based upon time versus a clinical need. That's a critical difference. So simply put, individuals are going to be returned to the community, which we may say are not at a level in which they can healthily navigate the day-to-day actions around the community. So in response to this, we see the funding that I think I referenced about the critical crisis 24/7, which they sort of see as a partial solution from the state to be able to address these needs. However, we also recognize that this is a capacity issue. So, and just to put this really, really simplistically, if this is about bed space, let's say, individuals being able to access higher levels of care. Well, when we need that space, it should be available to us because these are individuals who are in a very, very acute place. Now, if those beds aren't available to us, well, then where does that individual reside? Now, that individual might reside, say, in a jail setting or at the emergency department. So these are places that are sort of acting as the safety net, which in the past would have been managed within the state hospital system. But now these systems are having to navigate these pieces. So on our end, what we sort of see, our community resiliency, our community health means that we have, I think I mentioned the ACT team, the assertive community treatment. So teams such as ACT and other programs within the county system now have to start to bridge services around these individuals in an acute place. It means we're trying to navigate individuals who really, for all intents and purposes, would still be residing at the state level. So this is definitely a challenge. Yes, we have some financing to go behind it. Yes, we're going to see some FTE come through the door, which is going to take a while to respond. But in regards to those bed spaces, et cetera, that capacity hasn't been built. It doesn't reside yet, which means that leaves us as the county safety net provider. And this is the critical piece. The local mental health authority, everyone represented, on this committee, the local mental health authority ultimately is the individual entity that is responsible for this in terms of ensuring community safety. There's a lot of discussion around the state around how counties can be placed with that type of responsibility with minimal resources. So that's kind of a longer answer. So my apologies for taking it, but I do think it is an important one because I think it has bearing on the importance of this budget and us moving it forward so that we can ensure those services get stood up.
Thanks, Steve.
So I'm going to cover just a quick, there we go. Cover a quick overview of the policy packages that are presented before you from the health department. One thing I just want to note really quick, back to April talking about goal 3. it mentioned pending grant. I just wanted to make sure that the budget committee understood that we did not build that grant and it made any assumption that the grant would be in this particular budget. So while April is still working through that, once we have identification of that, then we would work into a budget supplemental to add that. But I just wanted to make sure, in case you were curious if we built it, because sometimes those are kind of built forward, but we did not build that one forward. So just real quickly to do a quick overview of what the policy packages represent for the health department. It's $1.5 million that has been recommended as a budget increase to the current service level. And that includes 11.32 FTE in total. So they requested 6 packages. In which they had requested 2.275 in total. And then of that request, I think this is important to note that only 20,000 of that was general fund discretionary dollars. The reason I mention that is in terms of the recommendation, and just again, as a reminder to the committee, these recommendations, the request came to the county administrator, and then these were all considered. And then the ones that are recommended to you are part of the proposed budget. But in some cases, or in all cases, we're having the departments present their entire policy package, just so that you have purview of all of the requests that were made. In this particular case, we approved it all. And the reason is this is all dedicated dollars. I mean, these are resources that we're getting, a lot of them from the state, a lot of them from charges for services, again, and all for critical services. So that was a recommendation. There is a request, and this is a bit of a technical issue that we'll talk about when I get to the non-departmental, but there's about 162,000 that we shifted away from their budget. And that's primarily because it's in ARPA funds, and that's part of the non-departmental. We didn't catch that initially. So I just wanted to let you know, but again, it is assuming full funding of everything. So then when you factor in the vacancy factor, of which that they had presented, and the shift that I just mentioned, that's what comes to the $1.5 million. So overall, again, as I said at the beginning, this would represent a 4% increase to their current service level budget.
Okay. Where I have the mic. Jumping right into these policy option packages. Number one has to do with our ongoing COVID response. As you may imagine, and it's a real reality for us, is much of the COVID funding that we received has been one-time funds and is rapidly deteriorating. We're fortunate to have some buckets of funds from OHA that were for pretty specific purposes and have been extended through June 2024. So we received a 1-year extension on these funds. And so we asked that 2 communications coordinators, 1 COVID-19 specialist, and 1 COVID-19 investigator positions be extended for that period of time. Just through that extension of funding. So the second request has to do with
April,
Yes.
on that, what happens July 1st, 2024 to these 4 positions?
those positions would end unless we have additional funding available to do the second year of the limited duration, which I haven't seen any indication that we will be able to do so.
Okay, thank you.
The second policy package has to do with our growth and our need to center health equity in everything that we do. The public health and healthy communities has continued to grow, both in that long list of programs that you've seen need, as well as our staffing. This request would be funded by public health modernization and increase in those funds. And it really is to have a centralized staff member dedicated to bring together these critical and inextricably linked areas of health equity, communication, health communications, and community engagement. Right now, we have individual staff members that conduct these work, and a lot of overlap, and a lot of people who have components of these elements across public health. Having a manager to make sure that there's that pass through and filter, our principles can be applied, and communications broadcast to all of our networks is something that would enhance our abilities to move health equity forward. Anything for that? Did you want to add anything, Sarah? Okay. Okay. So policy package 3 has to do with our work to establish a coordinated homeless response system. Benton County, along with the city of Corvallis, and soon to have multiple partners at the table, is engaged in bringing the efforts of many years past from our HOAC groups, I can't remember what that stands for, I'm so sorry, to our home opportunity planning and equity policy recommendations, to actually having a system to bring all of these pieces, the prevention, the providers, the funding pieces, the capacity building, all into one office of coordination, a centralized table through which all of this work can be conducted. So the request here is for the 2 limited duration positions that we have currently doing this work to make those permanent positions. And that is a project manager position and a grant writer position. The additional staff member that we have working on this is funded through the HOPE funds, which belong in public health, but structurally are within the office of the director.
And Mr. Chairman, just in terms of clarification in relation, this is the one piece that I had mentioned that is shifted from ARPA dollars, but I think what I want to make sure you're aware of is that the dollars that are funding these positions are one-time dollars. So it's House Bill 4123, which is the $1 million that was allocated from the state legislature. And then the HOPE is the dollars in which the board had allocated for this. I think, though, through the work of House Bill 4123, and particularly the grant writer, one of the very unique things about this is building that capacity and building that financial sustainability. I think we all feel confident in that work going forward, because that's a part of what we want to do here in the community, is grow that particular capacity. But I just wanted to make you aware that these are one-time fundings, but I will say that if necessary, I think our forecasting would suggest if we just had to use these one-time monies, we could get through the 25-27 biennium. So we do have a period of time, but our intent is to really try to leverage the positions to get more money.
I assume there's some talk in the current legislature to continue this program depending on outcome, or what's the status in the legislature?
Not yet. I know that there are 8 pilot communities for HB 4123 at this time. And all right now are working on their strategic 5-year plan, which will demonstrate sustainability and their plan towards sustainability, as well as a lot of the work that they're doing. At this time, I don't see anything forwarding that, but I do foresee the need for more communities to engage in this building of a coordinated response system.
again, never can tell, but I don't see that the state legislature would be extending these one-time dollars, as April had said, that they were for one-time pilots to help and be that seed money to generate the capacity. So I think the anticipation is that that money would enable us to continue to grow and develop capacity within the community. I do, though, think that particularly with the governor's agenda and the legislative interest, that there is going to be a lot of dollars out there for homelessness services. We saw with a huge package that was approved by the state legislature very early on. I think there's going to be lots of opportunities to be able to get either state and or federal dollars that can help our overall effort, not only this particular effort, but even further in terms of community services.
Thank you.
Okay, and Sarah will introduce us to package number 4.
Thank you. I just want to mention that that this particular package was tied earlier to the goal of implementing our health equity implementation plan for the health department, and those are aligned, but they're separate. So I just wanted to make that sure that was clear. What we are asking for here is to provide funds to support the Health and All Actions Committee, which has been in place for close to 20 years now, I think, but it's been called something different over the years. Health and All Actions, as you know, is one of the guiding principles for our 2040 Thriving Communities initiative. And this is the sister committee to our equity committee. We're asking for $20,000 for the biennium to support implementation of the Health and All Actions work plan, which includes embedding health and equity considerations into government operations and decision-making, to continue to encourage and support cross-departmental collaboration. For example, working on I'm just going to give an example, working on a park master plan together where, we can bring community outreach and engagement effort expertise to the project. That also includes funds for shared learning opportunities so that members of that committee and beyond can learn more about social determinants of health, cross-departmental efforts, et cetera. The current committee is made up of folks from different Benton County departments at all leadership levels, and took a pause during COVID, but we have resumed for the last year and are hoping to secure a budget for the biennium to move those efforts forward. The outcome is really to provide government services through the prism of health and equity. And again, this work is very much in line with the equity committee that's been established.
Okay, I hope that Jasper will speak to policy package 5.
Yeah, so as I mentioned, we're seeing kind of consistent and persistent growth in our program. And to the question, the increase is more people and more people accessing services. So all of our services are voluntary, and as we have services that are responsive to people's needs, we have more people accessing. So we've seen an increase in access. So we are asking for 2 things. We wanted to add another service coordinator position to just meet the needs of more people into our program. And then also because we have grown our services coordination, we have not grown commensurate with kind of the supervisory capacity. So we are at a point where we have someone who's working at a capacity now, but we do need to kind of make that longer term for our ability to manage the program. And then I guess it says 2 FTE, but we actually have 3 because we did get a special grant. We originally asked for 3, but we got a kind of special grant from the state for a quality assurance coordinator position that was originally in the budget that was already, that was already kind of fully funded by the state grant. And we do anticipate that most of this will be covered in kind of as our new state budget comes out. As with everyone, we're waiting on the May 17th revenue forecast. But we do anticipate that the growth factor that we're seeing is also being seen across the state, so that the funding for case management programs for DDU, should receive kind of at least a continuing service level increase at the state level. So we're hopeful that this will all be kind of covered by what we're seeing in our new state contract.
So question, when you say state contract, this says that it's self-funded. Is that where the funding is going to come from?
So, yeah, so most of our funding comes from the Office of Developmental Disability Services at the state, kind of under the Oregon Department of Human Services, with a kind of long-term care Medicaid. And every 2 years, we get kind of a new allocation, and the continuing service level across the state is higher. We haven't seen our specific numbers, and we won't know for sure, but it's looking positive that we will have the funds within our state budget. We also have a mechanism through the money the county gives us that we can, we perform at a higher level than the state expects of us. So we can draw down more money. And so one way or the other, we can certainly cover this.
Okay, thank you. So I guess another question is, if that money doesn't come through, then you still will be requesting the 2 FTE?
Yeah. And as I said, we fully expect it to come through, but we also have other mechanisms to raise the funds. These are revenue generating positions. So in a sense, we lose money by not filling them. We can generate funds if we fill the position and the person does the billable services. If we don't, then we have less funds available to pay for our county allocations. So we actually, it's kind of it's counterintuitive, but we actually have to spend the money to make the money, and we actually do better if we fill the positions than if we don't. And they are essentially self-funding positions.
Got it. Thank you.
Yeah.
Okay. At least Damien will bring us home with package 6.
Let's see. So I think what I'd like to call out on this piece is really specifically around the IHN rate increase. This just tacks on to what was just shared with you about the ability to generate revenue in addition to direct service. So we have multiple lines of funding that come in that basically focus through state funding that are sort of one-to-one in terms of our service costs. This allows us to then set up a situation in which we will have staff when they are brought on, that because they're involved in the Medicaid service delivery, that they will be able to then do billable services. Now, those billable services can be paid at a certain rate, and the gatekeeper of those rates are the local CCO. So in our case, that's IHN. During the last 6 months, when I first got here, we engaged in contractual discussions with IHN around our service rates to get to a competitive level in which we felt we could both fully fund all positions as defined, and also allow offset for cost of living and the time when inflation was just starting to really be discussed, to really sort of call that out. The challenge is that we are still in the position in which a competitive wage market for us to be able to hire individuals at a level that is going to attract people through the front door is still somewhat lagging behind the general state average. But our intent is most definitely to utilize our productivity as a way of getting there. And one of those things, just to tie it on again with IHN. So IHN, when they do a contract with you with the CCO, they offer up metrics. And they say they'll give you an array of 5 metrics to hit. And if you can hit all 5, they will give you 100% bonus of your amount. If you hit 8, if you hit 4, you'll hit 80%, and et cetera, et cetera. So the idea is that they have incentivized productivity, outreach, engagement, that type of work. So I can say, and I'm very proud of this, that our team this year met 100% of all metrics. What that means for us is financially, and what it means for the county is that then we get access to that CCO benefit fund. And that resides for all CCOs around the whole state. So every CCO has the ability to access those financial components. So I think in combination between Medicaid, productivity, the funds that we have, I feel very confident that we can present a budget that's going to be fully fundable and then some. So that's why, yeah, any questions on that?
Doesn't see deja vu when they get to the community health center. You're gonna see this exact same package in community health centers that represents the rest of it. Because again, and I'll talk a little bit more about this, the way the behavioral health division works is that while it's all part of the health department, there is a component of it that is within the community health center budget. And so a portion of this is also represented there. So I just didn't want you to be surprised when we get to the next and you say, didn't we just hear this? Damien will be back for more.
And Commissioner, do you have a question?
I did, and I was just absorbing what Rick was saying, because I was confused as to why the health department was making a policy package request for the CHC. That makes sense if they're, kind of woven together. So I guess I'm just trying to understand that, and I very much support the expansion of behavioral health.
Thank you.
And this, so the main funds would go to an additional staff in HR. Is that correct for support?
That is our goal. And we'll dig a little bit into the service delivery when we talk about the CHC. But I just wonder, this might actually be a very good spot to take a pause and sort of just give us, again, the 20,000 foot level of, how does this all work financially? I've been using a word a lot with Rick when we're discussing this, and that's chewy, because I think it's the only way we can really talk about it, because it is so, behavioral health funding really, really is complex. So we talked about a negotiated rate. Oh, thank you very much. Sorry. Second. Sorry. We talked about a negotiated rate contractually for the Medicaid funding with IHM. So if you think of that as them agreeing us to do an hour's worth of work and they'll give us $100 for it. Great, that's the idea. It's meant to be relatively cost consumed, one-for-one relationship in terms of how you do that work. Negotiated rates, there is some fluctuation around the state in terms of each CCO, but all in all, it's going to be a pretty much static amount. The beauty of having a CHC embedded in any clinical operation, whether it's behavioral health, public health, or other settings, is that it gives you access to another funding stream. It allows you a modifier. So if you can think of it, we're like the cake, and the icing comes through the funding from the CHC and specifically HRSA. So HRSA stands for. Okay. So on the CHC side, what that does is it sort of flips the switch and allows us to take that very same bill and process it through. So not necessarily about the service or the amount, but then process it through that area of funding and get the access to that additional amount of funds. And then that in turn goes into service delivery. I won't bore you in the details about what they do all with that, but basically what it is that it opens a doorway financially for us to be able to access, in addition to our standard payment, that we have a modifier on top. And we're going to talk about, I'm going to talk very briefly about this in the next presentation, but we will then talk about what is in scope. In other words, what is the service array that the FQHC can operate for behavioral health, and what is out of scope. So in other words, that same thing that we could bill, there's certain things we can't bill for. So that's the in scope and the out of scope. So hopefully, I literally, this is like a half-day discussion and we're still talking about it. It really is chewy stuff. So hopefully we can get some clarity around it and sort of understand how the mechanism works.
So it being self-funded, that revenue is coming from IHN?
Correct. So what we will see is, if you can think of any traditional payment within the CMHP as sort of two main revenue streams. One is we have. Thank you, community. It's keeping me honest. Community mental health program. So we have one that is coming directly from the state, which really is a one-to-one fixed rate that comes into the county. And then we have a rate that's controlled, an amount that's controlled by the CCO as a gatekeeper. And they're really like the incentivizer of a system. Are you seeing enough people? Are you seeing them in a timely fashion? The idea of a CCO really is you're managing a plan, right? They act for all intents and purposes as a classic insurance company. So we negotiate a fixed rate for all of our services, as well as getting direct line of funding from the state. Now, top of it all, now that's complex enough. On top of it all, we get the HRSA funding. So, this is where it starts to get even more.
So it's
complex.
IHN and HRSA.
So it's
Just- yeah.
it's 90% IHN,
Okay.
because even the HRSA funds are also accessing Medicare. And this is where it is a slippery slope, but it's just,
My apology.
no, not at all. And the rate has a lot also to do with the rate setting and most simplistically put.
Okay, I think you answered my
Yeah,
question. Thank
okay,
you.
sure. I don't go any further. Okay, thank you, Commissioner. I appreciate you cutting me off. It's good.
TMI.
I actually kind of crunchy, sort of breaking my teeth on it, so.
Thank you. Yeah.
Now we've just got sort of a list of some of our opportunities and challenges, and you'll see that we've listed a couple things a couple times here. We've all been through the ringer the last 3+ years, and as health department providers have really felt every moment of it. We've learned that we can be nimble, that we can be really thoughtful in our implementation, that we can really try to center health equity, even if we only have 2 days to pull it all together. We can do hard things together, and we can't do them alone. So we really need to strengthen our strong ties and continue to work to build new ones across the community and beyond. We've also seen delays to several bodies of work bursting, it seems now with urgency to become underway now. So there's a lot happening, from behavioral health to emergency preparedness and climate change to applying principles of health equity in all we do. There's so much challenge and opportunity simultaneously presenting themselves. We've got, as I mentioned previously, briefly, we've got several long anticipated assessments that are going to be moving into implementation phase, from our regional health assessment work to our climate and health work, or updates to public health emergency plans and our health equity work. All very exciting to move forward and a lot to move forward with. Very, very exciting. We've got all of this happening in somewhat of an atmosphere of increasingly uncertain financial situation, just hearing of another bank closure and having been around in professional spheres in 2008 and beyond, it's a little spooky. So we're really focused in, as we always are, but with being as collaborative, as communicative, as streamlined as we possibly can in all of our work. Yeah, and then there's this pesky virus that still hasn't been tamed. So we've got a lot to be excited and grateful for, certainly, and a lot of unknowns out there. And I'd be remiss, I know it didn't make it into our final slide, but we've got so much growth happening that we'll need a place for a lot of this growth to be housed. So we're wrestling pretty consistently with space conversations and how to house everyone. Did anyone want to add to any of those? Thank you.
Thank you. Any questions? Commissioner Wise?
Thank you. I have a couple questions. Sorry, I'm trying not to take up too much time. The looming fiscal unknowns, that sounds sort of dramatic.
Yeah.
Can you give me an example or?
No, I was speaking to the more of a worldview, US view, the bigger financial picture and having, been through big cuts previously in decades past.
Thank you. And then
Commissioner, if I can use your, because I know you're probably thinking in terms of, is there something specifically as it relates to the health department on any looming cuts? At this point, I think we see stability as it relates to that particular area. Obviously, the state legislative session will drive a lot of these races, like Jasper was talking about earlier for the developmental diversity program. But I think based on everything we're seeing, I don't want you to be worried. I think that this particular department is pretty solid as it relates to any financial issues.
Thank you for that clarification. And then you're under challenges and opportunities. You have everything everywhere all at once. I mean, is that just sort of an acknowledgement of the fast changing nature of the world, or is there anything specific in there?
Thanks. Yeah. So it really speaks to the fact that we've been through so much recently, and that we're embarking upon that's been paused, and that there's so much challenge and opportunity and all of these bodies of work coming back to the forefront, building back with community partners and internally with staff, connecting, back to our principles, moving health equity forward. So many examples of that. I tried to be broad so that everyone could sort of speak to what that meant for them, and try to do justice.
Thank you. And last question, this is just sort of in general, what kind of coordination has occurred with HR or will occur with HR when it comes to the FTE increases?
Thanks. I'd love to have Damien speak to that. If well, it was part of that package. I guess I could talk to capacity, really.
Sure. So one thing we noticed with all of these increases, I think for the committee's sake, so you understand that this also references the additional 10 positions that we stood up prior to this. So really, when you're talking about this, what you're seeing here, and then the additional FTE that you're going to see at the CHC and all my colleagues' FTE, you're really talking about an administrative burden that is now going to have to also be weathered by the county. I think there is a disproportional use of what I would refer to as the administrative backbone. So and that includes finance, that includes HR, in terms of those services being able to support the much larger entities. So as we grow, we should see some type of proportional relationship to the administrative backbone growing. And I think that's been a bit out of whack of late. We've been very blessed to get good funding from the state, and early discussions, we thought, and I threw it into the hopper, that we should also add additional positions on the administrative side. Rick was very patient with me. He didn't ask for anyone from finance, but it's not over yet. So that, but there has been, I think, especially on the fiscal side, I think pertaining to finance, a good reorging there as well. So I think from our standpoint, we saw HR as definitely one of those, areas that we need to support from an administrative side. So, and we are a colorful bunch of behavioral health, and we certainly use HR. So
very good. Well, and just said another way, your budget increase, you're looking for 11.32 FTE. HR is aware of that.
Yeah.
Thank you.
Yes. So, and Commissioner Wiseman, I just want to say thank you to Damien and the health department for recognizing this, because I think going forward in future budget developments, one of the things that I would really like to study a little bit more is when we are making these requests, how are we looking at the infrastructure component of this? And it's a little bit disconnected right now. And I think with some time, we can really look and make sure that we are always right sizing, or in some cases, maybe we're too high, or it could be, and I always say it's always too low, but I do think The glaring issue, and I think you heard both Suzanne and I talk about it in the Human Resources Department, it is a small team. And with all of the increases that we're seeing across all these requests that you've heard, that's going to have a dramatic impact on human resources, and it's harder than ever to recruit workforce. So again, appreciation for Damien and the health department on recognizing that.
Absolutely. Just one quick thing to add to that is that this is a real opportunity in that most of our funding is tied to very specific activities. So to have an opportunity to contribute in this way is not something that comes across our very specific program element or service element funding from the state.
Commissioner Malone, question?
Yeah, a couple things. Increased staffing. Obviously, that's a concern going forward. Just funding sources and grants, and I guess my main point would be keep us updated on how things are looking on various programs. I'm sure you're well aware of, oh, this is one-time funding and what do we do after such and such a date, kind of, but just hopefully not just treating this as, oh, we're done with the budget, kind of, but keeping us up to date, because it's a significant part of the county's budget.
Commissioner Malone, your music to my ears. I mean, what you're talking about is position management, and this is an area that we are going to be extremely aggressive about as we go into this next biennium in terms of our overall position management and ensuring that, you know, we have long-term sustainability. We're using limited duration positions when appropriate. We're making sure that if, you know, again, if there are permanent positions that are grant related, we're monitoring that all the way through and tying it together. So music to my ears, and I know that it's something that we need to continue to work hard on.
Okay, I love the term and the effort on coordinated homeless response. It was in the policy package number 3, and I think elsewhere in your presentation. But I speaking of music, that is. I think a really important effort that I'm glad we have that as a focus, emergency preparedness. That's something I've been involved with, not so much on the health side of things, but that is something that we need to try to be ready for. And so I'm happy to see that in the budget, and mentioned earlier what you folks have been dealing with COVID, and really appreciate all those efforts and the long hours, and because I think you have served Benton County well, and I know it's not over, but just what we've been through, and we got through in pretty good shape due to your efforts. And along those lines, thank you for bringing a good part of your team so we could, so I could put faces to names, and so that's it.
Thank you. Member Roberts.
Let me just say, I feel like I've been drinking through a fire hose through your presentation. And I don't think I'll do justice for the questions that I have, so I'm sure that I'll have some later. I have like this little journal of stuff that I'm gonna give at you, but I just wanted to touch on a couple of these finer points. The emergency response preparedness goal number 3. You know, that came up before. Are you coordinating with maybe the fairgrounds to make that an option for working on a space that could be for wildfire or any kind of challenges, because congressional spending packages, that sort of thing, to help fund that stuff?
Thank you for your question. We are looking at everything possible, absolutely, from leases to buying buildings and then renovating with community partners. There are reasons that certain existing buildings may or may not be a good fit based on location and transportation needs, where the population of folks may be centralized. But it is something that it could look any number of ways. You know, we had severe weather sheltering primarily in hotel rooms over this last winter, and we're learning that, well, maybe that's a really great option for some folks. Maybe it could be appropriate for families, and we could have a different model and sort of spread the opportunities out into different spaces. Suzanne?
And I would just add that public health emergency preparedness is its own body of work under the broader umbrella of emergency management. So April and team work closely with county emergency management in all of this, but there's this very specific body of work that is the responsibility of the health department. And then with regard to the severe weather overflow sheltering, actually, as we headed into winter, our interim Natural Areas Parks and Events Director, Jesse Ott, generously offered up the fairgrounds as an option. And we actually were headed that direction, but it's not ideal for many reasons. And some of that is proximity to service providers, other volunteers. Being in a core area can be helpful. And also, as we head into the other components, such as smoke protection during a wildfire season, for example, that may or may not be the best place. And whether or not we're looking at services to a particular unhoused population that we just need to be able to bring inside during, particularly overnights during severe winter weather, compared to a much wider array of daytime options in the summer when the hottest part of the day is, and then compared to that situation where we may have wildfire smoke that affects both our unhoused population, but also many other community members who may just be in a either an office building or a home situation that isn't that's letting the smoke in, and they may have special health conditions. So I think all those different plans going forward may require different kinds of structural solutions as we move along.
I think it was through Medicaid this last couple of years that they were offering free air filter systems to seniors. Was that an effective program that got out to people? Did people find out about that?
Yeah, people found out about that, and we through our countywide emergency management ordered air scrubbers as well, or they ordered air scrubbers after we passed the information along. So we should have the capacity should we have a smoke event here this summer or fall to do some air cleaning.
Super great. Okay, I have a lot more. Sorry. Do we have a group that works with law enforcement for those mental health crises that are coming up?
Yes.
These are great questions. Yes, we do. The acronym. I think it's an acronym. It's the core team. It's been in existence for about a year or so. Commissioner Orr is not because she's very familiar with this, probably more than I am actually. Currently, we have one FTE assigned. Oh, currently, I'm getting sorry. You're still good?
Yes.
Oh, look at that. Okay, so where was, okay, so we have one FTE currently assigned to it. We have one vacancy at this time, which we're looking to extend the hours. So right now we sort of have a 9 to 5 shift. That's obviously not optimal. Crises happen outside of that. So the goal is to be able to then have an additional sort of swing shift. The challenge goes back to some of the stuff we've already shared, which is about being able to attract qualified individuals. So at this level, it's a high level clinician. And it's a challenging job as you would manage. And then they'll be able to compensate for something that is competitive in the current wage set that we have available to us. So fingers crossed that we will see something, but it has been vacant for a while. But yes, we do, and it's a great partnership and it's a great model. I myself, I spent many years working for Lane County, and during that time, the work that Whitebird and Chrysalis and a lot of those outreach nonprofits working with local EPD has just really been a wonderful model to look at and to see how effective that can be in terms of community intervention. And of course, the last piece, as you know, is that we will be getting 24/7 crisis, which is going to be amazing. Which should be a really great resource.
Very good. Thank you very much.
Yes, you're welcome.
Crisis, outreach, respond and engage.
Yes. Thank you, Commissioner.
I'm so proud.
I could have guessed that. I could have gotten there maybe.
And the is it one full FTE? that's
One full FTE at this time.
Vacant?
Yeah.
No, on the vacant.
Yes.
On the vacancy, yes, it is. And both of those positions are currently funded. So there will be an adjoined relationship between the what we hope to be doing in terms of standing up on that 24/7 response. So there is going to be that correlation. But it's important to call this out. You know, our role within the county is obviously form a county footprint. Our goal is to be able to reach out into Alsea, to be able to reach out into Monroe. So the city is absolutely, you can't sort of avoid the fact that this is the large urban hub. So it's great that we have a partnership there, but ultimately as a county body, our responsibility as well is to be countywide. So that, we hope with that continued partnership that there'll be opportunities on the city side to be able to also stand up some models that might be able to address that as well. Because we'd like to be able to do this in Philomath. We'd like to be able to do this in other communities as well.
For policy package 6, it mentions that it's going to increase the capacity for the current waiting list. Will you be able to satisfy that current waiting list entirely with this hire, or will there still be a waiting list? Where does that leave us once you do that?
Again, I will go to the place of, if the cup is half full, it's going to be able to address in a dramatic way. Will it be able to address all of it? I don't honestly believe so. And simply put, because where we are at right now, on our children's side, we have enough responsiveness and access to be able to keep our wait time no more than 1 to 2 weeks in terms of doing that turnaround. The need on the adult side for outpatient services is so dramatic. We are looking at 2 to 3 months to be able to get through the door. For those that are trying to seek services right now outside of the county, so outside of our practice, that's just general practitioners in the community, with private insurance, and that even there's a lag time there. So for us to be a safety net services, we see more acute population coming through our door. They're majority Medicaid, they have high needs. It's hard to get into services. So that's not acceptable. We recognize, and the state recognized, that obviously that's not tenable. So our hope is that this will definitely dramatically decrease that time. I don't think it's going to be a perfect solution. And you actually heard this a little bit earlier. That is, space is actually an issue as well, to be able to then sort of house 10 new clinicians so that we can do that, with limited resources in the community. Again, another challenge. We're going to try our best. There's lots of creative solutions that I believe we can get to, but I certainly, I'm cautiously optimistic. There you go. That's where I'm at.
Sounds good. I think I just have one more. I would like to know what the glaring obvious health inequalities are within Benton County, the top 3, if that's possible.
Well, that's a timely question. We are in process of, we just finalized our regional health assessment, and some themes certainly emerged of those. I'm going to name a couple off the top of my head because I can't see how they wouldn't be on the list, and then I'm going to tag a friend or two to fill in the list. But certainly housing, certainly behavioral health needs, and I just don't want to guess anymore. So Sarah can list the additional of the 7 themes, right, that we came up with initially.
Yes, so April is right on. We've just completed our regional health assessment with our partners in Lincoln and Lynn County, along with Samaritan Health Services, IH and CCO, and the Confederated Tribes of Siletz Indians. Affordable housing, homelessness is on the list, behavioral health needs, substance use disorder, along with, I thought I could just rattle these off, but now that I'm here with you, I'm drawing a blank. Access to quality care, and then kind of equity, diversity, and inclusion, or structural inequalities also have risen to the top, along with food insecurity, and then healthy families, healthy children and families, or healthy youth and families. And so the goal for our region is to try to narrow the focus of those priorities for the community health improvement plan. And we're in the process of engaging with our communities all across the region to identify the top 3 that will focus on together to kind of bring more resources to the table and approach these issues through collective impact.
Thank you.
More?
Yes, okay. So just to tag on to that, I would say if we're to look at the intersection between all of those pieces together, if you're looking at houselessness, substance use, some type of behavioral health condition, access to some type of employment, and you put all of those together with limitations and or challenges, I think what we experience on the streets, what we're experiencing in our communities, what we're having with these discussions is that this becomes the sort of critical mass in which we really recognize our need to be able to respond. So all of these different areas, when they get to start to blur into one singular concern, it by nature of the health department, it becomes a population health issue. And I think for us, that is the beauty of our work, and it's the beauty of having a clinic from FQAC, it's the beauty of having public health, is that we can take this approach in terms of service around meeting each one of those areas, because it isn't one singular area, right? It really is how these all intercede with each other.
So much. Absolutely. We, as I said before, we can't do it alone, and it really relies on not only internally, but our entire community's partnership and collaboration.
Good. I think we're finished with questions. Yeah, great. Thank you very much, April.
Thank you.
Mr. Chairman, who would take a very brief break?
Okay. 5
5
minutes, 5 minutes, good enough.
Recording stopped.
Go back to work.
Recording in progress.
Hey, Mr. Chairman, thank you. We are on to our second presentation here. We have the community health centers, and joining me with help here today, Carla Jones, who is the director for the community health centers, as well as Lacey Malel, who's our deputy director. And of course, she met Damien last time, so he'll be on for a portion of this as well. So I'm going to start this by saying that this presentation is going to be a little different than the ones we've done so far, and I'm going to provide perhaps a little bit different and more financial information than what I have traditionally done. And as I prepared for this, it kind of reminded me a little bit of, thinking through my state career. Always, the Department of Human Services was always rebalancing a budget, and I can never figure out why can't you get it right the first time? I mean, why is it you have to keep doing it every quarter? Well, now I know, having come here to the county, the health center and health department for that matter, particularly the health center. I mean, it's ever changing. And the reason I say that is because when I get into this budget discussion, and I start comparing it to the adopted level, it doesn't make a lot of sense because obviously that budget has changed so much within just the 2-year period of time. And COVID has also, represented as we find to normalize. So when I go a little deeper this time, I'm going to be actually looking at reality and where we're at now. And that's really important as we set the context of the things that Carla's going to speak to in terms of balancing the budget for the community health center. So again, I just wanted to explain that if things sound a little different than what I have done so far. So with that said, I will start at least from the standpoint of the community health center's budget as a current service level. So again, we've calculated the budget the same way as others with our CSL as a $71.7 million biennial budget. So that's what we are estimating the cost is for our current operating going forward. That's 8% above the approved level. So take that with a grain of salt. Again, you'll see this as we kind of get more into the presentation. So based on that forecast of the cost, and then in comparison to the actual estimated revenue that we expected for this next biennium, we found ourselves about $13.4 million short. So that's a key number. I'm going to put that out there, and that's going to be sort of the basis as we start to drive through that. So what the reason, as I put here in the notes, the deficit is the result of essentially, our current operating revenues have not kept pace with the expenditures growth. So again, our expenditures are growing. Obviously, COVID had a huge impact on the health center with health centers across the nation. I'm sure Carla will speak to all health centers are going through this a great deal. And we have not been able to keep up with the expenses, the actual expenses forecasted going forward. So what we will be proposing as a budget is how do we get in balance? And that's really going to be 3 factors that we'll talk about. We are going to be looking at a significant vacancy factor and of about 3.75 million. Now, that's a big number, but it's not an unusual number when you look at the history. But we have to be really careful in this because there's also going to be position eliminations resulted in this as well. So again, I always like to say with vacancy factors, a very appropriate budget tool should be applied to all budgets, and particularly with the health center, because we've seen with their experience and they've been able to manage within their budgets when they've seen those low revenue trends. But that is about a 9.4% personal service vacancy factor. Just again, as a comparison of what we have seen over the last 6 years is upward close to 20%. So like I've said, with all the departments that had those really high ones, we don't want to go to the extreme. We want to come back to something that seems a little bit more manageable, and that would be around the 10%. We are also going to be proposing eliminations of positions, 11.0 FTE. Now, let me say that very carefully in that the positions that we're proposing are all current vacant positions, but they are part of the budget. So Carla's been very good about really looking at this carefully in terms of how do we continue to operate and provide the great services we do, but at the same time, aware that there are vacant positions that we can make strategic reduction. And then the biggest piece, and I'm really going to defer to my colleague here to my left, Carla, who's going to talk about the revenue side of this. I think that, again, there's an opportunity to really looking at recalibrating some of our productivity measures. I'm not going to even get into the level of detail because Carly can speak much better than I can about that. But her and her staff have done a lot of work to try to determine how do we recalibrate? I always like to say, how do we renormalize coming out of COVID in terms of looking at the patients that we serve and being able to generate and cover the cost associated with the center. So again, she will spend a lot of time talking about that. In addition, I want to just recognize Damien's here. There is this other, I warned you, I didn't want you to have deja vu, that there is a portion of this particular department that has a policy package. It's the other half of that behavioral health piece. One thing that's unique about this is that the dollars that are paying for these positions are what I call reserved or dedicated type resources, in which traditionally those dollars can be used for anything and everything. They will have to be somewhat dedicated going forward. So that's a little bit different approach that I'm going to have to work with Damien and Carla on as we move forward. But again, I just want to make that clear as we kind of go into this. So let me jump into just the categorical. I'm not going to spend a lot of time. I am going to note that I have made a mistake on here, the 11.0 02 FTE. And I failed to mention this in the front pages too. That should be, please correct that to 10.45. I apologize for the mistake on that. I thought I had caught everything on Friday, but I didn't. So that is basically the number that we want to be using in terms of the reduction. Again, categorically, 58% of this is personal service, so driven a lot, but they do have a lot of dollars into materials and supplies. Going forward, we're looking at in total 169.48 FTE. That's what, again, the current service level is at. That would include 59.91 of the health department, the behavioral health division, that is part of the community health center budget. Then, of course, we would propose the reduction of 10.45 and then the additional staff that come to behavioral health that nets out. So that's just, again, a quick overview of kind of the expenditure pieces in terms of categorical. So let me talk real quickly about the funding before we kind of get into a little bit more of the specifics. So the Community Health Center is essentially made up of two funds. So there is the Benton Health Center Fund, and then there's the Lynn County Health Center Fund. So those are completely separate. I want to make sure that those are, and they have to be, obviously, as it relates to dollars that support the Benton Health Center from the county's general fund, just goes to that particular fund and not to the Lynn. So that is the separation that occurs. But so both funds generate essentially prearranged payments from health insurance providers, as well as the Oregon Health Plan for enrolled patients and members. There is also additional, and I think Damien alluded to this a little bit, there's additional Medicaid resources that are coming through various variations of different types of mechanism that, again, I think Carla will touch on a little bit when she speaks to the revenue forecasting going forward. The other piece, again, that's, I think, very critical to both of these funds that was spoke at, you heard the term HRSA. That's, I'll just say, the Department of Health and Human Services at the federal level. This is a grant that goes to federal qualified health centers. Again, that supports both the Lynn and Benton, but that is a critical resource, obviously, is used for the operating resources for both the centers. I mentioned earlier in terms of the behavioral health dollars. These are the resources generated from also different types of billing mechanisms. One thing to kind of point out in the little pie chart you see there, where you have in total, the Benton Health Center is about 88% of all resources. But that pie, that little wedge that is yellow, that's 35%. 35% of those resources generate from behavioral health. So these are resources that come specifically in relation to the billing behavioral health mechanism. So it's a big component of the dollars. And you'll see as we start to go through this, It's one of those things that we have been able to use and maximize, but I think we've gotten to the point now where that resource has and its balance has essentially gotten to zero, to a place now where we have to be able to make sure that our expenses are equal our revenues going forward, because there isn't going to be a fund balance, at least not right now, until we're able to rebuild that. So then I think the last thing I will just mention, last couple of things in terms of the revenues themselves. There are a variety of other federal and state resources that come to each of these. Carla is always looking and applying for other federal grants, other state grants that come to actually support those. I know that's also part of her plan. And going forward is how do we aggressively go and seek out other dollars? I know that happens in a lot of our FHQCs around the state. We want to make sure that we continue to work hard to leverage those resources. And then the last piece is the general fund. So back again, the county does provide at least the estimate for next biennium is 1.582 million is the dollars that are transferred from our general fund to support just the Benton County Health Center. So those are kind of the quick overview of some of the key resources. This next chart, I'm providing it because it's sort of the basis of what we have been doing all of this, because again, this is an enterprise fund. It's really comparing it to the adopted level, which, as I told you, needs adjustment as it relates to what is reality. So in terms of your CSL increase of 8%, again, that is in comparison to the budget that was initially adopted. I'm not going to necessarily spend a lot of time. What I'd rather do is kind of move into this next piece. And this is where we're going to really start to look at kind of where we currently stand as it relates to the revenues and expenses for the health center. So I will start by saying, if you have to kind of look to really sort of dive into this, look at history. And we go back to 2017 and all the way through the current biennium that we're in right now. And so when you look at that, the average biennial revenue growth that we have experienced, and again, that's just on an average basis to give you some context, has been about approximately 16.6%. But then when you count in COVID and the dollars that contributed, if you were to take that out of the equation, the actual increases would have been less, would have been about 3.3% less. So about 13.3 is what we would have traditionally seen. Again, we're just focused on revenues here first. Then, again, the three different types of comparables here is we want to look at the behavioral health, because that's a key piece to this. We want to look at the non-behavioral health or the CHC revenues, and then of course COVID. Those are kind of three factors that we're considering. So first, the behavioral health. When you look at the growth that we have seen during that same period, it's about 29%. It's been pretty significant in terms of growth that we have seen from a revenue standpoint. But at the same time, the non-COVID CHC revenue has been about 6.9. So again, much lesser in terms of, and again, that's just to give you a sense of where some of the dollars are coming from. The one-time COVID revenues, they're all set to expire at the end of March. And for this biennium, that accounts for $2.8 million. So that's $2.8 million of COVID money that won't be there as we go into 23-25. So again, just trying to give you a sense of revenues in terms of what is happening as we start to compare it to the expenses here on the next page. So in 23-25, when we look just from a trending standpoint, so us accountants, us budget people, I mean, we get into it, we look at trends, we look at what's the history told us. And that's our basis for where we started this journey in working with Carla. And what we were basically seeing is the behavioral health revenue. Our forecasting was approximately about 7% for next biennium. Now, I want to state there, as Damien said earlier, this world of behavioral health is chewy, and we're learning a lot as we go. And I think that we're going to have to be doing some closer monitoring and some closer modeling in terms of the behavioral health. There's some interesting things that have transpired over the last 2 to 3 biennium between the children's outpatient program as well as the adult. And And I think there's just some areas that we may need to revisit those revenue forecasting a little bit closer with some modeling with Damien. But I think this is a conservative estimate. We feel good about where that was, at least from a current service level standpoint. The CHC revenues a little bit lower, was about 4% based on what our current estimate. So comparing what we've traditionally been seeing this biennium, we were anticipating 4%. And then when you put the elimination of the one-time COVID money into that, so the total revenue growth, what we were looking at for 23-25 from a current service level standpoint, 2%. So not a large increase. So that's where you look at those two little bars in the end. They're looking relatively close to the same. So COVID one-time money goes away and you see much lesser of a revenue increase. So now let's bring the expenses in. So now we can kind of start to look and compare. And this graph, I love looking at graphs, but it kind of, again, you go back to 17, 19, and you can see those two bars were relatively close together. They were, revenues pretty much equal expenses. But again, you've seen the blue, the light blue growing and growing, and the blue is trying to keep up, but it's obviously what you're seeing in there when you get to the current service level, that big gap. That's your $13 million that we're talking about. So now when we're talking about expenses, we're seeing about, on average, about 19% increase. So again, comparison, to the revenues growing at 16, the expenses growing at 19. Now, the drivers behind that, when you go back and look at the FTE in 2017, you were at 104.78. Now you're at 169.48. That's a 61.8% increase. So again, personal services is, we all know, that's our big cost drivers. That is the primary factor. Of course, then you have to add on to that, when you have more FTE, you have an increase in materials and supplies. So that means central cost allocation goes up. That means IT equipment and replacement goes up, office supplies, facilities costs, you name it. All those things are driven. One of the primary drivers is your FTE count. And this is one of our biggest growth areas in the county. And therefore, it has a lot of additional costs that are associated with materials and supplies. Also, and again, Carla could speak a little more better than I, but the contracted services, we've also seen significant growth in that area. I know that a lot of that has been managing because of staff shortages, needing to contract out to be able to continue to provide those services. I think that there are probably some opportunities. I know Carla's going to be looking at this carefully from an expenditure standpoint to see if, okay, are there potential savings, maybe more savings than we anticipated in the contract services? But I think it's a balance that she has to do, and that if you have less staff, you still have to provide the services. And so how do you juggle that effectively? I think another thing, it's important to note that, during all this time, there was a pretty significant construction component that went on here that with the Lincoln site, there was additional dollars that were obviously invested. I think it was unfortunately right before COVID. Things were back to these this bar chart. Things were in a good place. We were able to make that investment, and then COVID hits. So again, unfortunate timing, but that was obviously an investment that contributes to these expense growth as well. And on top of that, there was a borrowing. There was some debt service now that's in place for the community health centers for some borrowing of dollars. So basically, it is estimated by the June 30th, 2023, that the accumulated deficit position, when we look back at 2017, so if you look at all these bars and you kind of add it all up, is going to be approximately at a $4.7 million. And that sort of gets you to this next slide here. And so this just gives you it's pretty simple math, is that you see your revenues, you see your expenses, and you can see each and every year. Now, again, this is not budget numbers. This is real. This is actual expenses that we're looking at for 17, 19, 19, 21 that can give you an idea each and every biennium where we stood from the surplus deficit. Now, you may say, well, how did we survive that? Well, we survived that because we had a cash balance. We had a fund balance. And what I'm saying is that when we get to 21, 23 and this estimated, because this is based on the estimate right now, I believe it's going to be very, very, very close to zero by the end of this biennium, which means there's very, very little room for error. So this really is a long way to say that, we get to this current service level model on what we have estimated again, based on trends at 58.3. If you're looking closely in terms of the numbers, I am taking contingency out of this because contingency is essentially the dollars that you want to make sure you have at the end of this. I want to make sure I'm comparing to real expenses. So that's why you've got the $12,180,000 difference between revenues and expenses. And I'm sorry you can't see that very well down at the bottom, but just to kind of ground you to the 13.4, we're estimating a contingency of a $1.2 million at the end of this next biennium. That's still pretty small. That's still pretty small, but to get to that, it's going to require $13.4 million of a.
I want to just add one thing in or ask one question. Over those biennia that you're showing, there's also been a general fund contribution each year of, or each biennium
Yes.
of at least 1.5 million.
Yes, ma'am.
And we're assuming in this next biennium, another 1.5 million general fund contribution.
Commissioner Ogier, yes. And the 1.5 million is part of the revenues that you see there. So this is, like I said, a little different to that. What I'm doing here is grounding you to where we stood from current service level standpoint. So now what we're going to do is we're going to transition into, Carla's going to talk to you a little bit about the programmatic areas, just like you've heard from the other departments. But ultimately, rather than talking about policy package, all we're going to talk about one, which is the behavioral health component. We're going to be talking to you about the plan in which this $13.4 million will be resolved, and we'll get that to the end. So I'm going to take a quick pause before I turn it to my colleague here and see, is there, I guess, any general questions in terms of how I got to this starting point? I'll run it for you.
With that daunting information, my name is Carla Jones. Can you hear me? Is this on?
Yes.
Okay. And I'm the Community Health Center Director. I've been in the position permanently for a year and have been doing the work for a couple of years, a little bit of a stint in an interim role. I've been with the Community Health Centers for 4 years, just this April. Starting out in our quality improvement and data analytics department. The reason I wanted to give you a little bit of history is I think it's important for you to know that nothing, first of all, that I have ever been challenged with in my career has come easy. And I've had a lot of success getting through difficult financial states. I use a data-driven approach. I use a healthcare industry perspective. I look and leverage what my other peers are doing across the nation and statewide. And I have really good relationships with our community partners and our payers. So I know that that's a big number that we're going to achieve through projecting our revenues. And I know that we have a lot of cost savings that we need to take care of and do some scaling back. But I don't have any worry that it's not going to happen. So with me today, I have Lacey Millell. She's our Deputy Director of Clinical Operations. She's my better half in all of this work. First of all, it's her birthday today. So happy birthday to Lacey. I thought I'd bring her in front of a budget presentation.
With friends like you.
But the reason I thought she would be really helpful at this table is, one, if there's any questions around some of this work that's happening at the operational level, she's going to be your resource, and just to put a face with the name and who's working alongside of me to make this work happen. And then, of course, Damien. So without further ado, I will start by talking to you a little bit about community health centers. I think it's a little, but it's a kind of complex the way we have our structures for health in Benton County, and it is unique. So community health centers are fully qualified health centers where it's the Bureau of Primary Healthcare Bureau of Primary Care designates specific organizations to fulfill the mission of making sure that everybody has access to primary care. In addition, you can add other sources of care like oral health, behavioral health, enabling services, which are navigation employees who do a lot of connecting to services. So we have this federal designation to be able to make sure that regardless of whether or not you have the ability to pay, that you also have the right to healthcare services. And so Benton County, unlike a lot of other structures, has a community health center organization. Most community health center organizations are standalones. They're standalone businesses with their own tax ID numbers, and they are not connected to their local government. Ours is connected to our local government, and I, in my own personal opinion, I applaud Benton County for taking that approach and making sure that through a community needs assessment that you have the ability to make sure that our most vulnerable and impoverished individuals can seek care. Okay, so that's our fully qualified health center. And the reason I wanted to explain that to you is that although we have this umbrella of health services, we have the health department, we have community health centers, there's these intersections like you heard in the previous presentation that I'll also try to clarify here. We have been a fully qualified health center, a community health center since 2004. And at that time, we started out with our Lincoln Health Center, which is a school-based health center on the grounds of Lincoln Elementary School in Southtown Corvallis. After seeing that there's much more needs across the community, we then started opening up more clinics in Benton County. And then in 2008, established a relationship with Samaritan Health Services in Lebanon to open up a community health center on their actual business grounds. We have an agreement to use their facilities to host community health center services to the populations in Lebanon. And that happened and was established in 2008. And that's when our title formally became the community health centers of both Benton and Lynn counties. A little later, we expanded into Sweet Homes. So we have 2 clinics, which will, from the budget perspective, you have your 522 fund. Your 522 fund is your Lynn County fund. And the reason, to Commissioner Ogero's comment around receiving general fund monies, is we need to make sure to separate that so that Benton County general fund monies are not supporting Lynn County, and they do not. So we have our 522 fund for Lynn County, and then we have our 521 fund for our 4 Benton Health Center sites. Our federal designation provides for preferential reimbursement rates for Medicare, Medicaid in exchange for providing low or no cost services to underinsured or uninsured persons. In layman's terms, about 10 to 11% of our budget, of our revenues are grant funds that we receive through HRSA. You've heard that again a couple of times, but through the federal government, we receive about 11% of our revenue to make sure that regardless of your ability to pay, you can seek services. So if you are at 100% of the federal poverty limit, which basically means you make about $17,000 a year, give or take, then you can seek services for $0. Anywhere between 0 and 200%, we are able to implement what we call a sliding fee scale. That sliding fee scale means that there's a nominal fee, which we say this is about the average payment. This is a normal payment. And then we discount from there based on your income up to 200%. So you're still getting a discount to services, even though you have to pay out of pocket. After 200%, we do charge for services if you don't have insurance. But we bill commercial insurance, we bill Medicaid, we bill Medicare, and then we have these grant funds. And we have a few other grant funds as well, because we're leveraging as much grant funding as we can to continue to support these community services. I talked a little bit about our sites already. I did want to say that we also have an additional site at the Boys and Girls Club of Corvallis. We are co-located on the Boys and Girls Club grounds to host access to outpatient children's dental services. So we have a dental clinic there, and children and families are able to access dental care at that site. And then the last one is, so our revenue, like I said, comes from different sources. If it's insurance and or if it's grant funding, but really our revenue is driven mostly by our billable encounters, or otherwise known as services, or our patient panel sizes. So, and I should also say quality. So our patient panel sizes, due to some of our value-based payments that we receive through the state and through our CCO, we don't actually bill out a service to get a direct payment. We still bill out all of our services, but we don't get a direct payment based off that service. We get, like Damien kind of talked about, a per member per month payment based on who the CCO, IHN CCO assigns to us. So the more patients on our panel, the more revenue we generate from our CCO and from the state, because we also have a value-based payment methodology with the state. And then we also generate revenue by those billable services because of those other payer types like Medicare and commercial. In addition, we receive a lot of our money, it comes from quality payments. So if we achieve through contracts, meeting specific clinical quality metrics, for example, keeping people's blood sugars under control, keeping people's blood pressures under control who have hypertension, immunizing a certain percentage of adolescents and children, we will receive a large pool of quality payments. So those are our three big mechanisms. In addition, pharmacy billable encounters, and we'll get to pharmacy in a minute.
Can I ask one question?
Sure.
One of the things that I struggle with in terms of understanding the CHC budget is how the East Lynn Fund stays in the black.
Yeah.
Especially since Sweet Home is a big user of contract locums. And so I just don't understand the dynamic between the two different funds and why we're struggling so much, and yet it never shows up on the Lynn side of the balance sheet.
Yeah, no, that's a good question. In doing my own analysis and how it looks that way, and why 522, which is the Lynn County side, isn't as impacted, is for a couple of reasons. One, when we expanded into those two locations, we received additional HRSA money through an expansion grant to start up new services. And the way that our revenue streams, what has happened is that through receiving our HRSA funding, we still allocate kind of the same percentage as we received when we received additional funds to expand those services to those areas. And we'll get into that a little bit in how we transferred some of those monies to help with Benton. But due to that expansion grant, it increased the revenues the percentage of our HRSA grant that goes to those two areas. Also, we don't have as high as facility charges because we don't use, Samaritan allows us to stay in the Samaritan location for $0 rent. So we have no lease or rental agreement there. So therefore we don't have any facility charges. We still have to keep the lights on and things like that, but the facility charges are much less at that site than our other sites in Benton County. And then in Sweet Home, I just wanted to clarify, our locums are temporary contracted providers, primary care providers. Where we've been using locums most is in actually our Lebanon clinic and just a little bit in Sweet Home. I would say those are the big factors but we also have small care teams, and that probably helps as well, is having small care teams.
So in Benton County Health Center Fund, you have a variety of services that perhaps that you don't provide in Lynn County, such as you provide a lot more dental services in relation to Benton County Health Services. You also have family planning, I think that's built in to that. So there are some other areas that I think it's dependent on the Benton Health Center Fund to fund that as opposed to where you have that in Lynn County. Is that correct?
Yeah, that's a solid point. And then again, same with behavioral health. We don't have we use Lynn County behavioral health in Lynn County and not in this fund.
Before we go on, I understand. Member Jones, citizen member Jones has a question or comment. That's what I got. Jazz, are you there?
I do not have a question at this time, but I did just note, I just email or text Lindsay that I have to leave in just 2 minutes. And was wanting to apologize for that.
Okay. Thank you.
Thank you, appreciate it.
Thank you. Our mission is to provide a medical home that promotes and supports health and wellness. Medical home model, meaning that we're a patient-centered primary care home, and that patients can come to our clinic not to see just your direct primary care provider, but that you have a care team that wraps around you to help with your whole health. So we have RN nurse care coordinator. This includes their medical assistant, their customer service representative, clinical pharmacist, health navigators. So we have a real solid team that really creates that home for our patients to support their health and wellness. Our services, this is a bulleted point list of the services that we provide through all of but throughout our 6 CHC community health center sites. Obviously, patient-centered primary care services, family planning services, which is now referred to as reproductive health. And I've been trying to change that term. I didn't update that, Rick, sorry. Reproductive health, school-based health services. I forgot to mention that our Monroe Health Center is also a school-based health center. So we have 2 school-based health center sites. Dental services, behavioral health services, health navigation services, and that's really those clinical health navigators, pharmacy, outpatient behavioral health, intensive treatment services, and then housing services and medication-assisted therapy treatment services. Our organizational structure also gets a little bit confusing because of the health services umbrella and having the health department and the health centers separate. However, I think Rick did a good job of helping with this org chart to really show those shared services. So under our organization, the community health centers in the budget, there's 169.48 FTEs being requested. And out of the 169.48 FTEs, you'll see that 59.91 of those are under the behavioral health department of the health centers. And then the rest, the 81.17 plus 17.3, and then the 21.1, those are all under the primary care, oral health, and navigation services. The reason the behavioral health is in blue is because behavioral health reports through the health department as it's organizationally structured. We just share and integrate resources under the community health centers, but the authority is from the community mental health provider lens.
Just jump in real quick. I mentioned earlier that I made a little mistake on the FTE, the little red box, if you wouldn't mind. That's a 4.28 decrease rather than 4.85. And that top line that says 6.66, that's 6.09. I apologize for that. That's completely on me.
Another shared service, like you saw in the last presentation, is the health center administration. Oh, wait, never mind. I take that back. I retract that. This is a different fund that sounds very similar. Health center administration for us includes my position and some other leadership positions to help move our mission forward and help with sustainability. Lacey's position, that's really our health center leadership department or administrative department. These include employees that are responsible for establishing, leading, directing, and monitoring clinic operations and strategic initiatives. Additionally, the budget accounts for all funding, contingency, and revenue transfers between the clinic. And here's where you'll see Commissioner Ojero, the Benton and East Lynn CHC administration, the contingency, and then I think we're put down there below. Yeah, so the 23-25 proposed budget increased by $2,484,945 to account for a revenue fund transfer from East Lynn produced by. So we're transferring the revenues that we're forecasting over to the 521.
And just to jump in real quick on that, so Commissioner Ojero, to your point, traditionally, we don't see always a lot of transfers between Lynn and Benton. I mean, every once in a while, but this time around, because we made reductions in the Lynn County operations, it created a balance that could be available because you can transfer from Lynn to Benton to support that. So that's where that additional 2.4.
So the health center administration budget is an allocated component, in other words, and so by reducing that number of employees by or some that reduces the allocation and produces that.
You said it better than I. Yep.
Focusing in on our patient-centered primary care services, we provide the 6 locations for primary care. That's the Monroe Health Center again. And then the only other clinic I don't think I've mentioned yet is our Alcee Health Center. So we have our 27th Street building center, Benton Health Center, which is by Shintimony Park. There's Alcee Health Center, which is in Alcee. We have our Monroe Health Center in Monroe, the Lincoln Health Center on the Lincoln Elementary School grounds in Southtown, and then South Corvallis, and then our 2 Lynn County sites. Our total budget is $29,542,215. Total FTE is 73.32. And you'll see that some of the reductions, the 5.52 reduced FTE is specific to the primary care teams. And again, these are positions that were never filled from the last budget. So we're not going to be seeing any negative impacts to current employees. Behaviorists, we pull the behaviorists out, and I think we do that for the sake of, I'm really not sure. But what I would say is that I like it pulled out for the sake of being able to make sure that this additional care team member is a sustainable member on the team. And so behaviorists are different than what you'll see in behavioral health, whereby they're budgeted under the primary care budget because they're employed and integrated and working on site at our clinic locations, providing assessment and brief intervention and a little bit of treatment sometimes to behaviors that contribute to physical health conditions. So if you have a diabetic patient who is having challenges controlling their HbA1c, then the behaviorist can step in and say, what are maybe some challenges that you're having to being able to get outside and walk? And what are some of the challenges that you're having that might be causing your anxiety and depression, for which might be contributing to your HbA1c? And then they can connect to outpatient treatment behavioral health resources that Damien oversees and are out throughout the community. So it's nice to look at this budget separately to make sure that it's a sustainable method moving forward. Because if we're not generating the revenue to cover them, then we can't provide that extra service. And then we've got to focus, again, this is a continued focus from the last budget onto this budget and will be a focus and a priority for probably many years to come. But really, we're trying to make sure that we're expanding access to behavioral services where it makes sense and focusing on our medication assisted therapy treatment program. And that is the primary care component of prescribing treatment prescriptions to help with substance use disorders. So someone is addicted to heroin and they can use medication assisted treatments such as Suboxone to be able to say, is it Suboxone that treats? Yes. Did I do it right? I'm not clinical, but I'm getting better at this. Using, things like Suboxone and other prescriptions to be able to help with withdrawals and able to help them through their experience of being clean and sober. But it takes a primary care provider to write those prescriptions. So it's a very much needed service in our communities. We have almost 100 patients paneled to this service in Sweet Home alone. And so it's very much needed, and there's a lot of opportunity to improve it and to figure out how to create the best models for the we serve. Pharmacy, I forgot to mention, but good thing we have a slide, that one of our largest revenue streams is our pharmacy. So we have an outpatient, what they call a 340B pharmacy. And 340B, we're certified at the federal level to be a 340B pharmacy, which means that we are able to obtain discounted pricing on pharmaceuticals through claiming 340B certification and leveraging maximum revenue from pharmacy benefit managers, or otherwise known as insurance companies, basically, at average wholesale price to subsidize the community health center work. So to take an example, say you want an antibiotic and the antibiotic costs $10 normally, right, out of your pocket, $10. I can go and get that antibiotic for you for $5 because I have 340B certification. I can turn around and bill it if you have insurance to our insurance carriers and get my $10. And so the federal government stood this program up. I can't remember what year, but it's been quite a few years. And it was actually really pushed by Senator Wyden. He likes everyone to know he did push that forward. And it has helped subsidize community health center work for many years. We profit upwards of over $2 million a biennium in the black off of our pharmacy services. And this is your regular outpatient pharmacy. We actually don't employ the staff. We have a contract with OSU, and we staff the pharmacy. It's our pharmacy, we own it, but we staff the pharmacy with OSU faculty and residents. And let's see what else. Our primary focus is continuing to expand patient utilization by 8% over the next 2 years.
I have a question there. Since I've been with the county, every year, we have been looking to improve our fiscal situation by increasing pharmacy usage. Because as you say, it is a revenue generator. Do you have statistics for the increases in utilization year over year for the last few biennia?
Yeah, I can get that for you. I haven't. I think is it in here or
No,
it's not in here from the last year. I'll get the last goals and then be able to provide that later. We did monitor it pretty diligently when there was a goal of increasing it by 35% in 2019. And so I came in 2019 and thought, wow, that's aggressive. So started monitoring it immedately out of fear. And we were actually fairly successful in getting up to it was 38% over a 3-year period from 2018-ish up to 2017 to 2020. There was a 38% growth in pharmacy.
Thank you. I would like to see those numbers just so that I can validate, the probability that we'll be able to do an 8% increase.
Yeah,
and I know that usually that tapers off over time. You kind of saturate a market and you can't squeeze that much more growth out of it. But curious.
Of course. Yeah, pharmacy, and we could have a whole presentation on pharmaceutical companies and manufacturers and what you can leverage. But I will get those figures for you, Commissioner.
Sorry.
Question from,
On the on the pharmacy thing, I just want to make sure I understand this, because this is the first I've heard of pharmacy. Is this open to the public?
Yes,
Okay,
that's not correct.
No.
Excuse me. It is open to the public, but you have to establish care with one of our primary care providers.
so this isn't something you can say, this is a revenue generating, let the public know kind of thing then?
No,
Okay,
we can let the public know, but it has to be connected to seeking services with us, not just primary care, excuse me. It doesn't have to be just primary care. It can be oral health, it can be behavioral health across the spectrum.
okay. And where does the revenue go from this? Where does this feed into the revenue? What does it fund?
Oh, so the revenue generated funds first the expenses, so the contracted pharmacy expenses. It funds the materials and supplies. And then it's distributed across the rest of the clinics for their expanded services around things like navigation, and some of those additional services, behaviorist, but it's distributed across each of the other sites based on a patient panel kind of calculation. And I want to add to that one more bit of information is that by being a 340B pharmacy, community health centers are required to take those subsidies and put them into community services. Other entities across the nation can apply to be 340B, but it's not connected to the same requirements. And we're really pushing as community health centers through legislation that there be more compliance across the board, similar to what the community health center compliance is, so that we can really just continue to secure having that funding available throughout the years. Health navigation. So health navigation includes lots of different types of services and focuses on different lots of populations. We have what we call clinical health navigators, and they're actually considered part of our primary care team budget. They're not listed here. Those navigators sit in the care teams, are located at the community health centers to meet directly or be referred to directly to the patients seeking care at the clinic sites for direct navigation services, meaning let me connect you to community resources. Let me make sure that we keep you having insurance if you qualify. Let's see if you qualify. Let me help you with your diabetes education. And they also we have a lot of health navigators who are bilingual, bicultural, who are critical in helping much of our Spanish speaking population. We serve about, it goes up and down, but about 38% of our patients claim that their primary spoken language is Spanish. So we have a very large bilingual, bicultural employee workforce that helps with that population. We also have outreach and referrals to resources team that's what they specifically do in the community and provide eligibility assistance. And again, that linkage to community-based supports. We have interpretation and then our navigation training services. So we are recognized by the state, not yet accredited, for having one of the only community health worker training curriculums in our region, actually, not just the state, but in our region here on the Northwest. And we employ 2 trainers who are responsible for training the next generation of community health workers across the state. So people can enroll into our program. They're charged a fee, and then we train them in how to be not only a resource navigator, but also a clinical health navigator. Our family planning services. So family planning, otherwise known as also reproductive health services, is the new term. Reproductive health services are really geared towards following compliance with Oregon health authorities, reproductive health care rules and Title X rules. And basically, they're providing equitable access to high quality reproductive and sexual health services in all of our Benton Health Center sites at this time. And we do not have reproductive health services available in Lynn County because of a decision that was made many years ago, when Lynn County had their own reproductive health program and didn't want Benton County coming in and doing reproductive health when Lynn County had reproductive health. Since then, Lynn County, like many other counties across the state of Oregon, no longer offer reproductive health care services because the funding has dramatically decreased over the years. We too are needing to look at our reproductive health program, and that's one of the areas that we're going to spend some time in insofar as figuring out how to make it sustainable and what can we afford and having to scale back. But we do need to look at our reproductive health program in Benton County and figure out how we want to move forward as a county in offering those services. There is a program which is called Reproductive Access, where we do offer enrollments to the uninsured or others who cannot afford reproductive health services to enroll through the state, and then we receive payments from the state. We have a low enrollment because Medicaid either covers it, and we have a large Medicaid population, and or we're able to provide a sliding scale, and I'm sure there's other contributing factors around privacy. Right now, the reproductive health program, we're purchasing our supplies through our pharmacy, and we are billing out to insurances when we can, but a lot of the times people are hitting the sliding fee schedule. So really our priority there, it's okay, Rick, I don't have to read it. It's really just like I said, to how do we make this sustainable? How do we make sure that we're meeting the needs of the community and leveraging whatever resources are available across the community, developing the partnerships we need to really figure out where this fits and what we want to make sure we as Benton County make available to the dental services. So we provide affordable dental services across our community, and we have an outpatient adult restorative and treatment clinic at the 27th Street building here in Corvallis. And then again, we provide children sealants, preventive services, and treatment at Boys and Girls Club. We also are in all of the schools in both Benton and Lynn counties doing sealants. And we are at the veterans homes in Lebanon doing treatment services in teledentistry. So we're taking these low-cost services and we're really not only doing direct patient care, but we're focusing on the entire community.
I have a question with respect to dental.
Yeah.
Again, going back to when I first began with the county, dental program was another area that was expected to be able to generate revenues and really help keep the community health centers in the black. And I was wondering, again, same sort of request, what has been the track record of expansion of the dental panels, and it hasn't been able to pay for itself? And if not, why not?
So I can answer that a couple of ways. So we break out our dental costs in three different ways. We have our dental outreach services. We have our outpatient clinic, adult services, and then we have our children's services at the Boys and Girls Club. The outpatient adult dental treatment services, which is what we expanded, Commissioner Ojero, are nearly getting to a point of figuring out how to sustain. Our services being provided at our Boys and Girls Club and our outreach services continue to fall into the red and end up being we end up being in a deficit and not gaining enough revenue to those types of services in the community and at the Boys and Girls Club. And so it's a tricky answer, but we are not there yet. But when we look at that one area that we wanted to expand in, we're seeing that it's working. It's just going to take time. But we're also seeing a problem because we bucket all dental into one budget. And and it's showing a deficit more dramatically in those two other areas than before. A lot of the causes were, we used to have a huge referral base and payment base with our WIC services, and WIC services are starting to come back to being in-person services in both Benton County and Lynn County. And so we're hoping to see more patients through WIC and gain more referral to oral health, which is just a great service anyway for families. But we saw a big dramatic decrease in our revenues through COVID when we closed off WIC services and went completely, we didn't just in-person services, excuse me, we would never do that. But in-person services became more of either visiting in the home or phone calls.
Mr. Chairman, if I may do a quick process
Sure.
time check, because we were at 10 minutes until the end of this, and I know that we still have behavioral health to go through. We have goals to go through, and the big piece that we really need to focus on is the plan as it relates to how to fill the deficit. So I guess I'm going to look to you all for your wisdom and counsel on how you would like to approach. Do you want to extend time? Do you want to carry over? Or you want us to talk really, really fast?
I have to leave by 3:15 because I have
Okay.
another engagement at 3:30. I'd love to get as far as we can today.
Well, yeah, what would our options be for extending to a future meeting?
Well, what I might propose, committee members is, I know Damian he's going to be really, really fast in terms of we could kind of skip past the goals and go straight to the plan, and then we could bring the goals back at the beginning of the next hearing, just to afford Carla the opportunity to talk about her specific goals, just as a proposal.
However you want to do it.
Okay. All right. So we have until 3:15. Okay, with that,
Talk fast.
Okay, and talk fast.
I can talk fast. Okay, super abbreviated version. And I think just for the sake of the slides, I'm just going to give us another quick 20,000 foot overview of where we're going to go. And then we can just jump through all the slides. Basically, I think what I want to call out specifically is around the mission behind the FQHC, and it's how it incorporates our behavioral health services array from a financial standpoint. Most important thing to understand, there is an in-scope and an out-of-scope set of work. If you look up at outpatient behavioral health and intensive treatment services, those two specifically fall in scope. So traditional outpatient services that are really an adjunct to the care of physical health are something that you can then bill. So that really is the bulk of traditional behavioral services. If you remember that very first slide I shared with you guys, that was about the adult outpatient and the children's outpatient. So if you think of that as being the bulk of the work, that's the type of work we can do that we can then process our funding through, add an additional wrap payment to because of the being connected with the CAC, and do the work. The very last slides that I shared with you, and that was really around critical crisis services, those are the ones will be considered out of scope. And really, when we think of us as a local mental health authority, it's all of those local mental health authority jurisdiction requirements that we are under from administrative rule that really falls in the out of scope work. So, we see the opportunity going forward to help our internal processing and our internal support of the CHC in terms of referral-based commercial insurance. And I think most importantly, how we can sort of create a strong productivity value set around our work so that the clinic can really benefit and utilize us as being on site. I mean, that is ultimately our goal. Internally, we have a strong value set around productivity because productivity directly correlates to service provision. That means we're serving people. That's a mission. It isn't a financially driven, it's a mission-driven value set. So we believe that can translate directly over to the CHC. And with that, unless there are any questions, I'll be done.
So, what I think I'll do is, again, we want to get to the discussion of balancing this budget in terms of, back to where we started. We're at a 13.4 million. So you heard a lot of great things in terms of the current service level cost. One of the things I do want to point out, and Commissioner Ojero asked the question, I think Liz, you asked the question in pharmacy. So when we look at the various businesses without the community health center, and again, I'm going to speak from a budget standpoint. So I'm speaking of what my current service level cost is versus what my estimated revenues are before all these adjustments we're going to talk about. When you look at all the businesses, essentially our behavioral health and our pharmacy are the two that we see revenue surplus, and those surpluses go back throughout the rest of these other programs. And I always hate to use the word subsidy, but that's essentially they're subsidizing the rest of the programs for the health center. So again, I think we'll definitely want to follow back with you, Commissioner Ojero, in terms of some of the trends, but from a budgetary standpoint, from a current service level standpoint, that's where we stood with this $13.4 million deficit. So with that, I am going to jump you all the way to slide number 62, I believe. And we're going to jump into basically, the three components once again on how we would go about resolving this 13.4. So the first two I'll speak to, and then I'll turn it to Carla as it relates to the revenue recalibration. And there is a component of the policy package that adds into this, but just to kind of cut down to this, initially is the application of vacancy factor. So again, the clinic has traditionally seen vacancy. And I think I mentioned before we had seen, and I misspoke, but approximately about a 15.5% is what we've seen. What this would do would bring it down to about 9.4. So not as high as what we have seen in the past. It's still an area though, when you compound it with the next one of position eliminations, particularly since those are all vacancies, there may be some additional requirements that we would have to do to meet those vacancies, such as, holding positions vacant longer or doing what you can to try to meet those. Again, I'm not suggesting that we have to do that, but this is a vacancy factor that we'll have to look at closely if we're going to achieve it along with the position eliminations. So getting into the position, this is the one slide that I actually did get the numbers correct on the 10.45 FTE. This gives you a breakdown on where all those vacant positions come from. And the reason they're all kind of broken up a little bit, there are some cases where they serve across different areas. But again, we looked at and took a scan, I should say Carla mostly and Lacey, that took a scan of their operations to find out where are some vacant positions that they would continue to be able to operate and be able to save some dollars. In total, this is about $2.9 million that we would save. With that, though, after we had gone through those components, it still left us with a deficit of close to $6.1 million. And so the big piece of this is what we call the recalibration of revenue drivers. And this is where I'll turn it over to Carla to talk about what the plan will be to try to raise these revenues to the extent that we'll be able to meet the expenses. I'll just speak to the little chart off to the left. This is just sort of accumulation of all the work that Carla and Lacey and others have been doing over the last 2 to 3 months to really identify in each of those business areas that we've been talking about where they would increase in relation to their businesses. So with that, Carla, I'll let you take it away.
Thank you. Yeah, so a little over $6 million is a lot. And the way that we're going to do that at a high level is one, we have already been doing some of this work. So we've already negotiated a 6% increase to our IHN CCO contract. That is not reflected in the current service level yet. And so we think that by increasing the rate to IHN, that will help. And then we also we negotiated an additional $40,000 into our quality pool with our CCO. We're steadily increasing our primary care provider appointment slots from 8 to 12, from 8, that 12 to 18, sorry, this is where, starting from 8. So right now we're at about an average of like 8 appointment slots. We're increasing that with all of our providers, starting to at 12 and then phasing through the next couple of years to 18 per day. I don't know how to speak to that other than that is the norm for a community health center is up to 18 encounters per day. And we have a lot of opportunity to look at our scheduled templates and do more standardization and make sure that our clinics are providing the access that the community is demanding. And Lacey's been doing a great job at already starting in on this work. We're steadily increasing the number of assigned patients by 2,785 patients, which would put us at a grand total of 11,292 patients. And that would get us in alignment with what our UDS, our HRSA goals are. So our HRSA goals are to achieve eventually up to 13,000 patients paneled to our clinic. So this isn't over and beyond or anything irrational. This is an absolutely doable growth rate. Enhancing our mail order options and promotions for prescriptions received at our community health center pharmacies. Increasing patients served daily at our Boys and Girls Club, at school sites, at WIC sites, and at the adult outpatient site by approximately 45 patients per week. We have a whole entire plan built, sustainability plan built for dental on how dental is going to increase access to services. And then negotiating navigation contract with the CCO. So right now we are not getting any reimbursement from our CCO for our community-based navigators. And we're in the middle of negotiations with them and trying to work on a way to submit data to them for reporting so that we can start getting some payment for those services. And then credentialing and contracting with commercial payers for our behavioral health outpatient treatment services. And Davey and I have been working together with another team and better understanding our services and making sure that if we are open to above and beyond our Medicaid population and our uninsured population, that we are billing out those payers for those services. Are there any questions? In addition, I did want to add, I didn't talk a lot about the cost reductions other than the staffing costs, but we have also done a lot of work already and are continuing to do work on looking at our expenses and making sure we're scaling back until we see that each single area is at a place where it's being sustainable before we start thinking about expansion. And I think that's important because the materials and supplies expensive have gone up dramatically. And a big reason for that, like Rick alluded to, is our temporary provider staff. So we are spending anywhere around $30,000 a week in paying for locums, which are temporary primary care providers. We've already stopped those services and said we're finished with this contract with 1, 2, 3 of those contracts and are working on a 30-day plan for the other couple of contracts that we have in place now. So one, we know that locums are a last resort. We're going to do a better job of leveraging the resources that we have available, thinking about how we can incentivize our current providers to do more versus going and purchasing this very expensive salary, mileage, lodging kind of provider. So I did want to speak to that because that one continues to show up as a big red flag when you see something like 739% increase in materials and costs. And it's really those locum contracts because we've had a lot of challenges with workforce since 2019. And everywhere I go, if it's policy and issue forum in DC, or if it's locally here at our Oregon gatherings with our other CHC partners, the number one topic that everyone is talking about is workforce.
Mr. Chairman, just the one thing I want to add to this, the last piece Carla talked about, the third component there, we kind of skipped the pop. As I said, it was sort of the second piece to this, but as Damian talked about, this is related to a $6 and something increase in relation to our capitation rate. But with those dollars, while they provide staffing and opportunities to continue to leverage other resources, the dollars, any additional dollars that we get above and beyond that is restricted to workforce expansion. So you see that little note that I put down at the bottom, the $1.2 million. This is important because that money will be there, but some of it will be restricted. That's a little bit new than what we have done in the past. And we're still working through that. But I just wanted to make sure that you saw the entire picture to this.
Commissioner Malone.
Yeah, it seems complicated, a lot of moving pieces and trying to change direction somewhat. Who's in charge of keeping track or to make sure the trends are going like we want, or mid-course correction, well, we thought this would be doing better, but it's not, and we have to up our game in a certain area.
Thanks, Commissioner. I think that's a great question, right? Like, we should be monitoring and making adjustments as we go along. And then, like I said in the beginning, like, we're making very much data-driven decisions as we move forward and putting key performance indicators in place that we'll be monitoring on an ongoing basis. The direct answer is really, it's a team approach. We're using our quality improvement and analytics manager, Chris Campbell. Lacey is heading up a lot of this work as it relates to the access and the panel goals, right? As it relates to clinic operations. So patient panel goals and billable encounters, that's being monitored already. We use a platform called Power BI that's available and updated on a monthly basis. We're starting to roll out possibly up to daily monitoring of encounters per day, and making sure that health center managers are reporting to Lacey what does their encounters per day look like as we phase in 12 and then 13 and then 14. So we need to make sure that we are there to face the challenges that are being displayed on these daily monitoring sheets, to then put a plan in place to figure out how we move forward. Yeah, and then I was just going to add oral health, same thing with dental. So each program manager plus myself and a team of people are really putting the KPIs in place to monitor this. And then the bigger picture, Rick and Ahmed are really pressuring me and making sure that I have information given to them on a continual basis, so that we can all look at this together and see that the revenue is changing.
Can any of these changes show any progress before the end of this fiscal year?
I think some of the things that we have already done, so with the reduction in locums, like I feel like by the 30th of this month, we'll be completely out of our locum contracts. That doesn't mean the invoices will stop there for a little bit, right? Because they're a little bit slow, but we have been really intentional about getting out of those as quickly as possible. Additionally to that, we will be starting our, I don't know that it will by the end of this biennium that we're currently in, but we'll be beginning all of our access efforts June 1st, universally across. So I mean, technically we'll have a little bit of data in there with at least 30 days in by the end of July. So that way we'll know how we're going to meet those metrics. I don't know that there's anything else that we will be able to do specifically in this to end this biennium at this stage, other than we have been very proactive about looking at our cost. Carla and I are the only ones that are signing off on any expenses at this point. So a lot of requests to spend money are denied on a daily basis. I can say that.
And then we've already ramped up with oral health services and started providing more access to services on some of the days by adding one chair at the Boys and Girls Club and things like that. So those have already started. So we should start seeing an impact in oral health. And then we have already started working on negotiating some additional payer contracts.
Okay, thank you.
Commissioner Ogeron.
I was wondering, shifting from 8 appointments a day to 18 is obviously a huge change. And even going from 8 to 12 is got to be a culture shift for your providers. So what are you doing in terms of culture shift and just the management of
Yeah,
change.
this is very tricky. Yeah, the chewy is what you called it whenever you're describing, it is very tricky and change is a little bit painful, not knowing what it is. And I think focusing, we have spent a lot of time over the years, and I haven't been here. I'm just shy of a year right now, but focused a lot on the quality of the encounter with the provider. And so we've begun for months now, but really specifically working with each care team and provider along with their support staff. So their MA, because they're integral in making the patient workflow work, and helping them understand that the time in the room and the time with the provider don't always mean the same thing. Really reintroducing a lot of our providers. Most of our providers have been here for a long time. And so when we are, and today we had an interview with the PA candidate, we have a lot of potential opportunity for hiring new providers at this point, but they are all speaking a different language than our current providers are, just because they're used to what industry standards are. And so we're trying to leverage those relationships with our current providers, and then helping support them by reminding them of all these enabling services we have wrapped around our patients, to be utilizing those instead of them being the one in the room with the patient. So it's kind of it is slow, but it is getting faster as the water temperature is heating up in the bathtub. You know, they're starting to understand the need for it to happen a little bit more quickly.
And along that, I would just add that I'm also attending, we have a provider meeting each month. So every other month I attend the provider meetings to talk with them about how I need them to be champions and that they are leaders in this work too, and transparently sharing with them our financial state, and transparently working with them on engagement and having them work on what are the solutions to this problem, which I think will help, like the relationship piece of it will help change that culture as they're going along by understanding kind of what our state is.
Rick, I have an observation. So with 24 months, you're going to generate 6 million in new revenue. So is that coming in month 1 or month 7 or month 23?
So thank you, Mr. Chairman. Actually, that will be progressively through the entire
Is that
24
going to be
months.
tracked?
Yeah, because most of the dollars, the $6.1 million you're referring to, that a lot of it is from additional billing to, so to Carla's point is you go from 8 to maybe 10 to 11 to 12. I would anticipate that you would slowly see an uptick of that. And back to, I think the Commissioner Malone had asked, it's going to be imperative that we watch this like a hawk through this next biennium. There's no room for error here. And again, my job, of course, I'm always the bad one to kind of paint the dire, but this is what I consider a risky budget in that. And again, I don't say that in any, I mean, obviously it's just, there's a lot going on here and a lot of things have to go well. And we need to watch it every step of the way because there is no additional resources. There is no additional contingency.
Yeah, that's because if you don't make the 6 million, then it's got to happen somewhere else.
It's huge. The other piece of it is getting that overall population of patients up to 11,000. That's something that, we've been wanting to do for years also. It's a goal that I'm familiar with, and we haven't done it yet. So I'm curious to know how we're going to do it this time, especially with the fact that we're going through the re-enrollment right now, the process at the state. So it's, I think, going to be challenging for sure. And I'm sorry, but I also must run.
Yeah, I wanted to finish the last question really quick before I answer that one. You're right, it has to happen somewhere, right? So if we don't make the 6 million, then it has to happen somewhere. I think it's really important
for everyone to understand that that means that we have to go into this together. Because a lot of our costs are also county costs, right? So wage increases, when we look at wage increases, when we have, 60% of the FTEs across the system, that impacts us. So we really have to look at this as an opportunity to collaborate when we're really thinking about costs such as wage increases or adding more FTE in like HR and facilities and places like that. That is an automatic impact also. So I think that I'm looking forward to working more closely with some of the other departments and some of the decision making to see if it's something I need to do to help minimize some of the burden that might happen on some of the other departments because of expansion. But as I'm reducing, how is that impacting the rest of the county if I'm reducing services? So I think it's, we have to do something, but not just at a community health center basis. Like we have to look at the big picture as a county that's supporting access to direct patient services. And I'm looking forward to not having that conversation because we're going to be successful here. And then patient panels, all I would say to help lessen some of the concern is we saw a dramatic reduction in our patient panel sizes through the pandemic. And we're sitting somewhere at a little over 8,000 patients. Pre-pandemic, we were at a little over 10,000 patients. So even though that seems like maybe it's not doable, the fact that we lost that many and it's time for us to stabilize and recover, I think can reduce some of the fear that we're not going to be successful. We know that the demand is there, even with Medicaid redetermination. And the way that the state is rolling out the redetermination process, we don't really think that we're going to feel big impacts until much further out into the biennium because of the methodical way the state is doing that. So we think this is really our opportunity to leverage. So we're only assigned 10% of the Medicaid population in Benton County. We have to be assigned more than that. So it has a lot to do with better partnerships with our CCO. And there is we know the demand is there.
Goodbye, Commissioner.
Oh, thank you, Commissioner Giroux.
Any other questions or comments? No? Okay.
Okay, so Mr. Chairman, the plan will be this. I will bring Carla back at the start of the next meeting so that she could finish her goals. I think she'll probably have some closing comments in terms of challenges and opportunities. Not that we haven't provided you with not at this point, but certainly we see both its challenges and opportunities. So I'll go ahead and have her start the next meeting, and then we will have IT. My department of finance, and then I'll hit you with the non-departmental, and that will be it in relation to the final presentation. So, and then we're off to deliberations, which we have 2 days scheduled, but I'll certainly work with you if we need both of those days. Or if we just need one.
Thank you very much.
Thank you.
See you next Monday. Meeting adjourned.